Your Excellency Sheikh Nahyan bin Mubarak Al Nahyan, Minister of Culture, Youth and Community Development, Your Excellencies, ladies and gentlemen, distinguished guests, Assalamu alaikum, peace be upon you all. It gives me the pleasure to welcome you to the Emirates Center for Strategic Studies and Research in its own conference, the first Arabian Gulf Public Health Research Conference, Interventions for a Healthier Future. And we start this event with a speech by His Excellency Sheikh Nahyan bin Mubarak Al Nahyan, Minister of Culture in the United Arab Emirates. Please, the floor is yours, Your Excellency. Good, there is a perch so that one would not stumble. In the name of God, the merciful, the compassionate, and praise be to the Lord, and blessings of God on the Prophet Muhammad. Ladies and gentlemen, distinguished guests, participants in the conference, Assalamu alaikum, peace be upon you all. I welcome you and greet you, and I have the pleasure to be among you today in the first Arabian Gulf Public Health Research Conference. I really welcome convening the conference in this city, which complies and corresponds with the action plans of the Minister of Culture, Youth and Community Development, based on measuring and following up the levels of public health as an essential factor that determines the levels of development in society and honestly reflects the economic and socio and urban environment, and it is rather an indicator of the quality of life and the extent of our success for a better health for human beings. I have the honor to extend my gratitude and appreciation to the sponsor and the patron of this event, His Highness Sheikh Mohammed bin Zayed Al Nahyan, Abu Dhabi Crown Prince and Deputy Commander-in-Chief of the Armed Forces of the UAE and the President of the Emirates Center for Strategic Studies and Research. We are proud of his patronage of this event, and this patronage is an extension of his continuous efforts that concentrate on finding a successful integrated system for public health care in Abu Dhabi in particular and the UAE in general. And we pray to our Lord and we thank our God that we feel the systems and the signs of this success in our own system, health system, and we are proud of the excellent services provided by all standards, and due to and thanks to the wise leadership, Abu Dhabi has an effective public health system concentrating on prevention, diagnosis and treatment of diseases, a system that realizes international standards and a system that is closely related with the objectives of socio-economic development, and a system that makes Abu Dhabi an international pioneering hub of successful and developing health care at all levels. It is appropriate to say that this conference is being organized here in Abu Dhabi to deal with public health issues in the Arabian Gulf area, and it is appropriate also to hold this conference in the United Arab Emirates, this country which moves with determination and insistence on the path of finding an integrated public health system as per the international best practices. And we thank our Lord and our God that the United Arab Emirates, under the wise leadership of His Highness Sheikh Khalifa bin Zayed Al Nahyan, the President of the United Arab Emirates, may God bless him and preserve him, has always been seeking to provide dignified life to human beings and raising the levels of health care and providing excellent public services, public health services as per international standards. And thanks to the wise leadership of His Highness, the President of the country, Sheikh Khalifa bin Zayed Al Nahyan, the United Arab Emirates is a successful country, an advanced nation that finds that health is not a matter of treating of the sick people, but in its wider conception includes physical health and psychological health and moral health and the health of the community at large. Rather, it is supported by structures and policies and systems that would contribute to the raising of the standards of living in our own community. We live in a state that finds this wide scope of health is an important and essential factor in the socio-economic development, and that health is a fertile area for integrated efforts of all the sectors of the community and government. I have the honor today from this forum, I would say, on the public health research. I would like to submit to His Highness Sheikh Khalifa bin Zayed, the President of the UAE, our own appreciation and respect for His Highness's great attention to the public health system as a strong foundation for socio and economic development, sustainable development, and we are proud, in fact, of his great achievements that the United Arab Emirates seeks to achieve its own prosperity, progress, and welfare. Ladies and gentlemen, as you know, talking about public health is or means talking about the community health at large, which means that we are talking about all social, economic, and environmental factors that determine the individual's health and also the community health. When we talk about this subject, we talk about the patterns or lifestyles and the behavioral risks that are related to health, such as the diets and exercises, traffic accidents, the use of dopes, and talking about diseases, diagnosis thereof, and the plans to prevent these diseases. When we talk about it, we talk about the progress in the field of medicine, the introduction of new treatments and new medications, and the quality of the institutions of healthcare and the qualifications of doctors and nurses and the medical staff. And we talk about the perspective of the community of health and the position of health in the social development and how to mobilize our efforts of all institutions to serve these clear-cut and crystal clear objectives in this vital and important field in human life. All these are very important matters in the Arabian Gulf area, which witnesses rapid and unprecedented developments as we witness high rise in the standards of living and lifestyles, and also a retreat in the spread of communicable diseases, and also an increase in chronic diseases. And we witness also a rise in the age of the population, or the and also expectancy of life, and also a rise in the population. And we also expect a high rise in the population, and also in the medical services to be provided to the population, and also the surging costs and expenses of healthcare, and also the repercussions of globalization and the open world or the global village world, where diseases and infections can cross borders easily and cover distances easily and quickly. And in the region there is also a social dialogue on how to deal with all these developments and variables in the region. And here there are some important questions. How would the public health system respond to these diseases and these factors? How could the state and private sector organizations work together as an integrated system to develop the health of the community at large? And how can we make use of the successful stories across the world? And how can we measure and follow up the standards of health in the community, and taking these standards as foundations for procedures and policies, or wise policies for the future? Perhaps you may know that all these matters were discussed in our own communities at large in the United Arab Emirates, and these discussions were culminated in the discussions led by His Highness Sheikh Mohammed bin Rashid Al Maktoum, UAE Vice President, Prime Minister and ruler of Dubai. And it was a chance and an opportunity for brainstorming, where the whole community took part therein through the social networks channels. It was a kind of a very positive social networking that came out with important recommendations and proposals, stressing the fact that medical and health services must be given the priority on the map of national work in the United Arab Emirates. Ladies and gentlemen, it was very clear and evident that during that ministerial meeting, and as it is seen in this conference, that the country and the region and the world at large face challenges in the field of healthcare. And I have been noticing that you have chosen an important theme, that is the interventions for a healthier future and how to deal with the chronic diseases that are increasing and spreading in the region and representing a heavy burden and a big challenge for the healthcare systems worldwide. I do agree with you that chronic diseases represent the biggest challenge of health systems in the present and the future. For example, we find that the spread of obesity, for example, and inactivity and the bad nutrition styles leading to a rise in the figures of diabetics and cardiovascular diseases and strokes and other types or kinds of cancers are chronic phenomena that are closely related and associated with lifestyles and environmental conditions. Your conference today will shed light on these phenomena and diseases and carries within its own program the seeds of optimism and of our own capacity to face this challenge and to mitigate its own consequences on the health of individuals and communities. Your conference is a kind of reiteration that success in this field would require planning at the health level, which is closely related with socio-economic planning and policies, and we have to take intelligent and smart strategies, integrated strategies that, in my own opinion, would focus on 4 important axes or topics. The first one is the necessity of having a national and regional, international strategy to deal with the chronic diseases and the populations that have their own specific characteristics. For example, those who suffer from diabetes, for example, and those who suffer from cancer, and those cardiovascular patients and the kidney failure patients, for example. And this would include also children's diseases and healthcare of the elderly and the persons with special needs. These strategies should be an essential and vital part of the healthcare in the community. The good preparation for these strategies would require also the encouragement of scientific research in this field, and it would require also the collection of data and facts and the analysis thereof, publication of periodic reports, and the public health system by its own nature is very complicated, that requires information and continuous research and full knowledge of the requirements and needs of the diversified community groups. This is a very important aspect of our own work that we miss in our own practice, unfortunately, in the Gulf region, as we find it very rare, in fact, to have statistics and studies on the region. And I hope that your conference would come to proper recommendations to correct the position. And the second topic, or the second axis, is the realization of equality in the work of hospitals and all medical units, and paying special attention to the role of primary healthcare units, making them as the first defensive line against chronic diseases. concentrating on education or raising levels of awareness and early diagnosis of diseases and building strong relations with the surrounding communities. And this, of course, requires the continuous development of the medics and the physicians, and how to provide the continual courses, training courses for those physicians and doctors and nurses. Besides, we have to provide the best methods of medical information and how to get open to the international experience and to adhere and observe international standards, and how to establish partnerships with hospitals, international hospitals and outstanding medical institutions. It is very important, ladies and gentlemen, to have outstanding standards and criteria for the measurement and the success of the constituents of the health services in the region and the country in particular. And it is necessary to have a clear mechanism to realize this fact on the ground. And I think that it is high time that we establish national commissions or even regional commissions to adopt and approve or accredit hospitals and issue licenses to these hospitals and to their own staff according to advanced international criteria. The third axis, or the third topic, which is very important in my own opinion, is that the process of awareness and prevention should be integrated with the process of diagnosing the chronic diseases, and we have to raise the levels of awareness regarding the reasons of these diseases, and we should have continual awareness campaigns in schools, universities, hospitals, and primary health care units, working sites, and NGOs, civil society, and the media, and this would include also taking measures that would strengthen prevention of these diseases and raising levels of health or public health in communities. And among these procedures is to have, for example, periodic testing and the early detection of diseases and the prevention of smoking, for example, and the encouragement of exercises, sport activities. Time flies. This center has been established 20 years ago. Yeah, 20 years of rich and great achievements. Thank you. So the prevention of smoking and the encouragement of exercising, proper nutrition, vaccination campaigns, protection of the environment, cleanliness of water, clean air. All these measures and initiatives are important and required. And the last axis that I suggest in this field is an axis that is referred to by many researchers, that is the enhancement of the role of individuals and the public in facing chronic diseases. There are nowadays available technologies that would allow individuals to play a larger role in the field of detection and examination and the nature of chronic diseases and their own association with the lifestyle of individuals. This would require that the individual should be an effective participant in facing this challenge, and it is high time also to establish the relationship between the state and the individual in the field of healthcare. And the government or the state provides the reasons of health and healthy life, and the individual will have his own or her own own responsibility for his own lifestyle and to be more preventive in their own behaviors. And I look forward to hearing your own discussions and your own recommendations on this important issue, which is seen as an essential part and a foundation for the reshaping of the public health policies at all levels in the country and the region. Ladies and gentlemen, distinguished guests, I do appreciate the initiative of the Emirates Center for Strategic Studies and Research, ECSSR, in organizing this conference, and I'd like to thank you all for your concerns to deal with the challenges of chronic diseases, hoping that your conference would come out with recommendations to stress the confrontation of these diseases in the region, and to come with findings that would enhance the strong community determination to provide the resources for success. And let's remember always that spending on facing these diseases is an important investment in the future of the community. It's an investment in the type and the quality of life, and also the socio-economic development, sustainable development. And let's remember also that our success in facing this challenge is not the responsibility of the health institutions only, but it is also the responsibility of individuals, NGOs, and all other organizations in the world. And I wish you full success in your own deliberations to enlighten our path for a healthy and successful development in the Arabian Gulf. And God bless you all. Thank you very much indeed. Thank you, Your Excellency Sheikh Nahyan bin Mubarak Al Nahyan, Minister of Culture. And now I give the floor to Dr. Jamal Sanad Al-Suwaidi, Director General of the Emirates Center for Strategic Studies and Research in the United Arab Emirates, which I have the honor to deliver on his own behalf. In the name of Allah, the Merciful, the Compassionate, Your Excellencies, distinguished guests, I welcome you all, ladies and gentlemen, and most welcome to your second country, the United Arab Emirates, and at the Emirates Center for Strategic Studies and Research, where the first Arabian Gulf Public Health Research Conference is being held in collaboration with the RTI International under the slogan of Interventions for a Healthier Future. Ladies and gentlemen, the United Arab Emirates Center for Strategic Studies, since its own establishment in 1994, has always been seeking to consider and examine all the matters that would raise the levels of services provided to human beings in the United Arab Emirates at the social, economic, and all levels, including health services, because man is always our own target and objective in the strategy of the wise leadership of this country, represented by His Highness Sheikh Khalifa bin Zayed Al Nahyan, the President of the United Arab Emirates. And we have, for this purpose, we have organized scores of workshops, seminars, and conferences, issued many books and publications to realize this great achievement, that is to provide health care for our own nation, an integrated service across our country, even in remote areas where we have dedicated dedicated or allocated funds for healthcare. For this year, 2014, we have allocated 3.7 billion dirhams in comparison with 3.4 billion dirham for 2013. That is an increase of 8%, and hence the first Arabian Gulf Public Health Research Conference, which is being held here and is a continuation of the message of the center, not only for the progress of mankind or human beings in the United Arab Emirates, but all our people in the GCC nations and the Arab world and the humanity at large. And besides that, the objectives of this conference concentrate on the decisions of the 34th summit of the leaders of the GCC nations that were held in the state of Kuwait last December 2013. What motivated us to organize this conference is the excellent success that we made in the, especially during the last decade, in the health system in general. Even the World Health Organization put the United Arab Emirates on the 27th position among all the nations of the world in their own health systems and the high quality and efficient services provided to citizens and residents. And although it is important, but it is less than our own ambition, and we have been working according to strategic plans to be the #1 country in the world. And the aim of this conference is to know how to keep up with the technological developments and modern information technology in the world, and its active role in improving the efficiency and the quality of health services and the optimum use of human and other resources in the health sector, in addition to exploring the recent trends of the e-health in order to produce the best model and system for services to our own people. Also, it gives us the pleasure to brief the participants of this conference on how to prevent the chronic diseases like diabetes and other things by using the modern systems, and this would require from all of us to continue implementing and developing a clear-cut strategies and long-term strategies and national plans for public health care in our countries to complement the resolutions of the 68th conference of the GCC Council of Health Ministers held in Abu Dhabi, United Arab Emirates in April 2010. I hope that we can come out with practical recommendations to accelerate the realization of the aspirations of our people by providing them with the highest quality system services and healthcare. God willing, wishing you all the best and having a good stay in Abu Dhabi and the United Arab Emirates. Wishing you good luck and thank you very much. Assalamu alaikum. Peace be upon you all.
Now I'm honored to invite Dr. Wayne Holden, President and Chief Executive Officer, Research Triangle Institute from the United States of America.
Holden.
Thank you, and welcome to the first Arabian Gulf Public Health Research Conference. I would like to express my own personal appreciation to Sheikh Nahyan, who has been a strong supporter and advocate and a sponsor for RTI since we've been involved in our work in the Emirates and in Abu Dhabi for the last 8 to 10 years. I would also like to express my personal appreciation for Dr. Suwadi for working with us collaboratively over the last several months and certainly in the last several weeks, and his staff to organize this conference and bring everybody together. And it has been a wonderful partnership and relationship up to this point in terms of the meeting. And everyone here who has traveled from afar, I'd like to welcome you, those who are here from other countries, as well as my colleagues from the United States who have come here to participate in the proceedings today. Before I get started with my formal remarks, we actually have a video that I'd like to play that will give you some information about our organization and help you to understand the things that are important to us in terms of our mission, our values, and our passion for addressing important public health problems and other problems in the world. Thank you. A few other pieces of information that might help you to understand what our organization is all about and what we're interested in terms of our work here is we're an independent organization that's 55 years old. We have 4,000 worldwide staff. We have 1,800 ongoing projects in 70 plus countries around the world. We are very interested in improving the human condition by conducting research, but our focus is very much on applied research and applications that have a direct impact on changing things in the world and making things better for humanity. We span everything from basic work in drug development to policy evaluation and policy implementation. And a large focus of what we do is in public health. We have been working in this region for more than a decade. We have especially worked in Abu Dhabi and have enjoyed our partnerships here and feel that we have had an opportunity to impact not just work in the environmental area, which has been a big component of what we do, but also in the health area. This first conference is going to be addressing an extremely important topic, as the other speakers have said. Public health is obviously an important issue worldwide, but a particularly important issue in this region of the world given the parameters of the health concerns and the problems. Chronic illness has become a worldwide issue in terms of the epidemic status of chronic illness and how it will continue to grow and evolve in terms of prevalence over the next several decades. The reality is that on a global level, we've had successes in improving maternal and child health. We've had successes in combating infectious diseases. And as populations age and as populations become more prosperous, chronic illness has become really the issue that we need to focus on. The most recent estimate, that's a conservative estimate provided by the World Health Organization, is that over the next decade or two, it's likely to cost, on a global scale, $30 to $40 trillion to address chronic illness. That's a conservative estimate, and as we all know, economists have problems with predicting accurately. There may be several economists in the audience today. So it could likely be 2 to 3 times that. That's about a little over half of the current global GDP that will be expended on chronic illness. So it's obviously a huge and important issue with respect to humanity, the health of humanity, and our economic success in the future. The topics for this particular conference, I think, were well chosen and important issues in the area of chronic illness. It doesn't span everything that's important. For example, things like cancer, which is an important chronic illness that we are combating in multiple and different ways into the future, is not included. But the topics of cardiovascular disease, the economics of obesity and the issues associated with obesity, the burden of illness with a focus on diabetes, and the issue of how to utilize mass media and mass media campaigns to improve the population health across time are very critical and very important. I had the great opportunity and the great fortune to visit Abu Dhabi about 4 years ago. And what I also did during that trip is I presented a paper at the Jeddah Economic Forum in 2010. And I believe I recognize faces of individuals who may have been there. In that paper, I talked about the economics of healthcare into the future, and I think some of these issues obviously are continuing to be very important, and some of them have been talked about by the speakers here and were discussed in the VIP lounge prior to coming in here. The importance of evidence-based decision-making, making decisions based on data, making decisions based on research as we develop approaches and systems for improving public health and improving our approaches to chronic illness. The critical importance of continuing to reduce tobacco use. It is now 50 years since the first U.S. Surgeon General's report on tobacco. That report was so controversial that it was released in the United States on a weekend when Congress was not in session and when the stock market was not operating because of the concerns about policymakers' reactions and the economy's reactions to that particular report. In the United States over the last 50 years, there has been significant work in tobacco control, and significant work still needs to occur. But the reality is the use of tobacco has reduced substantially since 50 years ago. And it takes significant effort over decades to deal with particular public health issues like tobacco control, like obesity, and like nutrition. The enhanced use of information technology is also critical and very important to what we do in the future. And it's becoming even more important in terms of the comments that were made about individuals and individual responsibility. We can now receive feedback as individuals on many parameters of what we do, almost instantaneously. We can pull up our cell phone and touch an app, and information becomes available to us for decision making. The continued integration of information into individual decision making and across systems that are providing health care will be critical to addressing chronic illness in all areas of the world. And finally, the last issue that I think is important, and I talked about several years ago when I was at the Jeddah Economic Forum, is the importance of continuing to focus on primary care and promoting the development of primary care. One of the critical mistakes that many cultures, countries, and societies make in the world that they have resources is that they invest their healthcare resources in very specialized care, very high-tech care. And that may address health at one end of the continuum after disease has already been diagnosed, after interventions are needed. But it neglects the opportunity to provide preventive interventions and to affect large populations in terms of promoting their health status going forward. And that is a huge policy issue for all countries moving ahead, is providing the appropriate workforce and having primary care available, having clear access to primary care available so that people's health can be promoted, monitored, screening can occur, et cetera. So over the next 2 days, I'm sure that our colleagues here who will be on the panels addressing these issues will touch on several of the things that I talked about. And I look forward to the discussion. I look forward to the development of relationships and the renewing of relationships that always occur in these kinds of venues, and the opportunity to come up with creative and innovative solutions that have a significant impact on the problems that we're all confronting. Thank you very much.
Thank you, Wayne, for this speech. والآن مع استراحة لمدة 20.
Now we'll have a 20-minute break and then we'll start the first session, preventive measures against cardiovascular disease and strokes. Please, thank you very much. We'll have also a group photo with His Excellency, the Minister of Culture. Thank you very much indeed.
Please, Dr. Wayne, if you can.
السلام عليكم ورحمة الله.
Peace be upon you all.
Session, ladies and gentlemen, we really appreciate you taking time from your busy schedules to be with us today in this important gathering. I can briefly reflect on the introduction in this meeting, and then perhaps go forward with our two talks in the panel discussion. As His Excellency Sheikh Nahyan highlighted in his opening speech, and also His Excellency Jamal Sanad al-Suwaidi, this is truly an important meeting for us to have. And I think also the highlights of the importance of this talk was also highlighted by His Excellency Dr. Holden, that in our region, on one hand, we have succeeded in eliminating many communicable diseases. However, we are suffering as a result of issues that are very important to public health, and that is chronic diseases, non-communicable diseases, with a huge economic and mortality and morbidity burdens to our societies, and that has a direct impact on development in this part of the world. It is indeed a pleasure for me to be invited to this panel, and also for my organization. I am the Chief Academic Officer for Abu Dhabi Health Services, the organization that manages public facilities in Abu Dhabi. Being a nephrologist and also having a public health hat, I can relate to this meeting very well. So I think we want to take this discussion to the next level and try to reflect on the different forums that these two interesting days will have us focus, and perhaps even come up with some conclusion recommendations that this government could put into implementation. So we would like to start with the first session. So let me introduce to you Professor Kenneth Labreche. He is a senior fellow at the RTI International, who leads projects in evidence-based guidelines, systematic evidence reviews, guideline interventions, and the use of electronic health records and devices to improve healthcare quality. He has received his BSEE from MIT and MD from University of Minnesota, medicine residency training at Brown University, and cardiovascular disease fellowship at Harvard Medical School. He had successfully led a number of national, international initiatives that actually transformed into major population impact. I wouldn't want to be unfair to the whole introduction, but that requires a talk in itself. So I would encourage you to take advantage of Professor Labreche attendance with us. You can read more about his background on page 12. And also, I would encourage you to use the networking time to interact with our panel attendees. So he is going to talk to us about improving prevention and treatment of heart disease and stroke. And in particular, he's going to reflect on interventions that work. And he is highly qualified to discuss this topic for us. And hopefully, if we finish on time, we have a plan to open it for questions and answers with our panel. Please welcome Dr. Kenneth Labreche.
That's a good start. Some help to get this open.
Your presentation is here.
Is this it?
You don't have video, right?
I gave it to folks in the past.
So it seems we have a little technical challenge to get the slides, but as we prepare for that, let me update you on a public health initiative that is with regard to public engagement into some activities. In the United States, in the honor of the founder of this nation, Sheikh Zayed, in 2003, it was announced to have Zayed Charity Marathon and in support of the Kidney Foundation in the US. That initiative had thousands of people participate, and it resulted in donation and fundraising more than 140 million dirhams. So this marathon is coming to Abu Dhabi.
That's not mine.
So as of end of this month, we are starting the Zayed Marathon in Abu Dhabi. So we encourage all of you, your organizations, to heavily participate and have the public engagement in these initiatives. Thank you. We'll pay you attention, you pay money.
There we go. So my apologies for that beginning. It's always a little bit of a challenge. I actually have a degree in electrical engineering and computer science from the Massachusetts Institute of Technology. And so there's an expectation that computers will always run perfectly when I touch them, and sometimes when presentations are missing, that doesn't happen. So let's move right ahead into talking about improving prevention. Ooh. Oh, here we go.
Yes.
Okay. Into improving prevention and treatment, because we know we have this very large problem with cardiovascular disease. I want to put it into the context of non-communicable diseases as really a global problem, as evidenced by the work of the United Nations in 2011 to recognize this as a major threat to world health. I'll talk a little bit about the U.S. Approach to prevention and treatment of cardiovascular disease and what we've learned over the last 20 or 30 years, and then some very specific examples of how we can improve the delivery of evidence-based medicine and reduce cardiovascular events. So sort of beginning at the beginning, we know that non-communicable diseases are a major problem throughout the world. And here in the Gulf region, they're a particular problem with the rate of dying between ages of 30 and 70 from non-communicable diseases being among the highest in the world. When we look specifically at non-communicable diseases, we see that cardiovascular disease is the major overwhelming cause of this premature death, both heart disease and stroke. It exceeds other non-communicable diseases by nearly twofold. And so when we think about this, one of the things about the U.S. is we had a head start in communicable diseases, and people have been dying of heart disease and stroke for some time. This graph shows progress that we've made over the last roughly 50 years, particularly starting in the late 1970s. And over that period of time, both in the US, in Australia, the UK, and in Canada, we see that the rates of mortality have fallen by more than 50%. And there are a variety of reasons for this. And so this article in the New England Journal of Medicine tried to parse out where this decline in mortality has come from. And as we can see here, about half of it is a result of improvements in the delivery of clinical interventions. This includes technical interventions, revascularization procedures, but by far the largest part is in secondary prevention. So medications that we know will reduce recurrent events in those that have had events. The other half is in the realm of public health. During the next 20 minutes or so, I'm going to focus mainly on clinical interventions, and my colleagues over the course of the next 2 days will talk a good deal more about public health interventions. I do, however, want to call your attention to these last two bars in terms of body mass index, obesity, and diabetes, because these have actually had a negative impact on the reduction in mortality, or they're actually leading us in the wrong direction. So these continue to be very substantial problems in the United States and throughout the world. And as we've already heard, here in the Gulf region, these are particular concerns. So a big part of how we make these reductions in death rates and in morbidity is by translating what we know in the realm of efficacy. That is information from clinical trials, the development of evidence-based guidelines, into effectiveness. That is actually having these evidence-based therapies delivered as a matter of routine to every patient, every time. And to get from this gap that we often see between what we know and what we do in practice requires some very specific and dedicated activity in terms of building systems, and that requires leadership and often a change in culture in the way in which care is delivered. The notion of a care team, there are a number of individuals that are involved in the care of patients, and they all have an important role to play in the delivery of this evidence-based preventive care. And so one of the examples that I would like to use is a cluster randomized trial called Young Hearts, Strong Starts that we recently completed with colleagues in 2 academic medical centers in the U.S. Led by my RTI team. This was funded by the National Heart, Lung, and Blood Institute, the NHLBI, which is a part of the National Institutes of Health. And the background here is we know that the development of cardiovascular risk occurs at a very young age. And so the exercise patterns, the nutritional patterns that are formed, to a certain extent genetic traits, lead to the development of atherosclerosis that can be seen in children and adolescents. And so our prevention measures that start later in adulthood start with a background of atherosclerosis, the baseline of heart disease and stroke already having been established. And so in 2011, our National Heart, Lung, and Blood Institute developed a series of integrated guidelines for cardiovascular health and risk reduction, which put together all of the information about the kinds of interventions that can be done in children and adolescents to prevent the development of heart disease later in life. Now, guidelines, as I mentioned earlier, are part of efficacy, so then how do we translate those into regular practice? Well, it's been observed by the Institute of Medicine that from the time of scientific discovery to the time that these discoveries have become part of regular practice is about 17 years, of which 5 years occur after the guidelines are published. And so we used to think that you publish a guidelines, everyone can read the guidelines, and so they do it every day. But there's a good deal more to it in terms of developing effective systems. So the purpose of this study was to see what kinds of interventions can be done to speed up this process from 5 years to as little as 1 year. And so we developed a multifaceted intervention that is a number of things that we do in terms of tools, in terms of strategies, in terms of changing the way that practices work in the delivery of care so that they will really focus on these three areas: body mass index, blood pressure, and tobacco. There are a number of other things in the guidelines. For purposes of this trial, we focused on the three most common issues, and we looked at children who were being seen for their well visits at age 3 to 11, and we did this over a 1-year period. So this next slide illustrates just the timeline here. We did independent outside chart review to look at the performance of pediatric practices and seeing patients in this 3 to 11 age group. We presented the baseline data to an intervention group of practices and a control group, 16 practices in each of those two groups. With the intervention group, we did a number of other things to help them improve care, and then at the end of this period, we did another chart review to see how well they'd done. So the intervention consisted of a number of things. One of the things is that at the beginning, the intervention group had a visit from a respected leader in pediatric care who was very knowledgeable about the guidelines, who brought the baseline data for this individual practice. So they had an expert who could talk about the guidelines, strategies for using the guidelines in routine practice, and the information about how well the practice was doing at the very beginning. We also provided quality improvement training for physicians and their staffs, and we did monthly webinars, so online trainings that included sharing among practices, because practices who are engaged in the sort of change in the way they deliver care are often the real experts in how it's done. So hearing from a peer that I found a way to ensure that all of my patients, when I see them, have their body mass index calculated. We have the percentile, because in children it's all based on percentiles. All of these things are done when the physician sees the patients, as just an example. And so we went month by month. We also had experts talking about specific areas of the guidelines that people were working on, provided some coaching, and then we put together this project with a requirement from the American Board of Pediatrics. Our specialists are all certified, but that certification needs to be renewed about every 8 to 10 years, and part of that process is engaging in quality improvement. And so this project for the practices participating became a way of meeting those criteria and maintaining certification. And so it's a way of putting together incentives. My team developed a series of tools, including concise guidelines. The guideline that was written was more than 400 pages long, and so we put that into very concise terms of exactly what needs to be done and how it needs to be done. Slide sets so that they could work with their staffs to make sure that everyone was trained. We created a booklet aimed at both patients and their families to help them make changes in their lifestyle and behavior. Particularly for children, children tend to eat what their parents give them. And so creating healthy lifestyle options, exercise activities that the whole family can do, avoiding spending long times in front of computer screens, which our children seem to like to do a lot these days. I know my own do. Were a series of strategies that could help change the behavior to more healthy lifestyles. And then one of the pieces that we put together, Dr. Holden mentioned this a little bit earlier, is a clinical decision support tool. And this tool, it can be used on smartphones, on tablets. It involves using the touchscreen applications that we're all accustomed to in smartphones to put in the basic patient information, and then it produces a series of recommendations. Instead of a 400-page guideline, one has a screen or two with all of the recommendations. And what turned out to probably be the most important feature of this is we have very simple calculators. So with blood pressure, practices were very good about measuring blood pressure, but with children, to understand what that blood pressure means, you need to calculate percentiles. This turned out to be very difficult because there are a number of tables that one would need to go to based on guidelines that had been published 4 years earlier, and basically no one was doing it because it was just too complicated in a single 15-minute practice visit. And so we were able to develop this calculator that made that very easy. And so here's sort of the bottom line over the course of a year. These are the results. They were presented at the American Heart Association meetings earlier in November of 2013. This family of curves demonstrates from left to right the control baseline, control follow-up, and then the intervention group baseline and follow-up. And so the first bar on the extreme left is a composite of all of the measures for the project. And the good news, if you look at that yellow bar, is that the intervention group improved a great deal more than the control group, and that was significant. When we look at body mass index, performance was actually fairly high. Both groups improved, but at about the same rate, because they'd been working on this for 6 or 7 years before this project started. With blood pressure, however, we saw that the control group made basically no progress during the course of the year. The intervention group, with techniques and with this clinical decision support tool, made very significant progress. And also the final piece in terms of counseling children about avoiding tobacco, avoiding secondhand smoke, their parents, avoiding exposing the child to smoke, and parental smoking cessation also showed significant improvement compared to the control group. And so there are a couple things that I want to call your attention to when we look at this data. So in the interpretation of blood pressure, that's this calculation of percentiles that this tool was designed to make very easy. So if you look at these numbers in the control group on the extreme left here, less than 1% of patients were having blood pressure percentiles done, and that didn't change over the course of a year. The same was true of the intervention practices at baseline, but more than 60% of patients had percentiles calculated over the course of the first year. So this is really the power of some very simple technology and the process of getting this done on a regular basis. And that is one of the measures that actually drove the kind of that we saw. And then overall, at the very bottom here, we saw that on average, these measures were happening about half of the time, which is pretty much what we had anticipated. And there was about a 13-14% increase in the intervention group as compared to the change in the control group. So this was a positive study demonstrating that we can work with practices, provide them tools, and increase the likelihood that children will receive evidence-based interventions to reduce their cardiovascular risk. Right now, we're looking a little bit more at this control group. Control groups in these sorts of intervention studies are very interesting because they know the trial is going on. It's not like our usual randomized controlled trials. And so we have some additional data from them that we're analyzing now. Now, the final part of this is a large program in the United States that we started about 14 years ago called Get With the Guidelines. And it's designed for hospitalized patients who have heart disease or stroke. The components of the program include bringing together organizational stakeholders in recruiting hospitals. We now have almost half of the hospitals in the United States participating in this program. We have a collaborative learning model that is exactly what we did with the pediatric practices in terms of learning sessions and sharing of best practices, so I won't say much more about that. The tool here is an online tool that combines decision support and data collection. And then the final piece of this, we did this in conjunction with the American Heart Association, so we provide recognition for hospitals that are high performers. And I'm going to give you just one or two examples in the interest of time, but these are a series of measures from patients hospitalized for stroke. So starting on the left here is the use of clot-dissolving medication, thrombolytic therapy for patients who present with acute stroke. This needs to be done within the first couple of hours of hospitalization. And we see this family of curves is year by year performance of the hospitals that were involved in this project. This represents about 142,000 patients, and we see this increase in really all of these measures, the acute measures, and then measures like aspirin at discharge, treatment of cholesterol with statin therapy, smoking cessation counseling, and we saw substantial improvement that continues year to year over about a 5-year period. One of the questions that sometimes comes up in these sorts of observational studies, different than the control trial I showed you earlier, is how do we know that participating in this particular program it was associated with improvement, or would this just have happened anyway? In the United States, there are a lot of efforts that are going on to improve hospital quality, and so we were able to tease that out of this study with this analysis using multivariable logistic regression to try to find independent associations between hospital characteristics and performance. And what we found here is that the usual characteristics of hospital volume, hospital size, didn't really seem to be associated with performance at all. The two things that were calendar time. We have hospitals that enter this program continuously year after year. So some may have entered 3 or 4 years ago, some within the last couple of years. And so this calendar time is a way of looking at these so-called secular trends, and there is an association. But the stronger independent association is time within this quality improvement program. So the longer you spend and get with the guidelines, the better your performance will be. And this is just one more look at the same measures, this now over a 7-year period, with the first 1 million patients entered into this, this registry associated with Get With The Guideline stroke. Now, it's fine to measure improvement in these sort of processes, starting patients on medication, doing what the evidence tells us. The real question is, does that really improve outcomes? All of the evidence on which guidelines are based would suggest that's the case. So here is just one example of how processes translate into improved outcomes. This comes several years ago from an integrated health group, hospital and office group called Intermountain Health, in which they began in their patients with heart attack, acute myocardial infarction, to institute standard therapies like aspirin, ACE inhibitors, statin therapy, beta blockers, warfarin, and anticoagulant for patients with atrial fibrillation. Starting in 1999, they were able to get those numbers up to about 90%, and they made several observations. The first is that when a patient started on evidence-based therapy in the hospital, paired with an acute event, they're about 90% likely to continue that over the first year. There are about 4 or 5 observational studies from various parts in the world that show the same thing. When they looked at their patients with heart disease who had heart failure, they were able to demonstrate almost a 23% reduction in mortality. Even in patients without heart failure who tend to have lower rates of mortality, they reduced that rate by about 20%. So these processes translate directly into improved patient outcomes over the first year following hospitalization. So, in the United States, like in many countries in the world, we're in the midst of this non-communicable disease epidemic, largely driven by obesity and diabetes. There are multiple efforts that are going on in the community and clinical settings that will make a difference in the outcome of patients, our citizens. And I think that many of these things are translatable to other parts of the world. There are projects going on now in Taiwan, in China, in Brazil that have applied some of these techniques, and so they do seem to be translatable to other places. And I believe that over the course of the next couple of days and going forward, we have a lot to learn from each other about how we can stem this epidemic of cardiovascular disease and stroke as part of the non-communicable disease epidemic. Thank you for your time.
Thank you very much. Very interesting talk and lots of ideas. So let us move to the next talk. This is by Dr. Yunus Kazim. He is a medical director, consultant, and head of vascular surgery, Sheikh Rashid Hospital, Dubai, UAE. Dr. Kazim has over 17 years of experience in vascular surgery. He holds memberships in the European Society for Vascular Surgery, European Society for Surgery and Surgical Research, and the German Society of Vascular Surgery. He did his medical training in Egypt and underwent his postgraduate surgical training in both in Dubai, followed in further training in Germany. Dr. Kazem started his surgical career as a specialist, moved on to a full consultant role within the Dubai health system. He had contributed in a major way in advancing surgical interventions. So us reflecting on medical as well as surgical innovations in the intervention that helped the population. So Dr. Kazem will be reflecting on that. Please welcome Dr. Kazem for his talk.
Assalamu alaikum. Good morning. Bismillah wa salatu wassalam ala Rasulillah. Actually, my talk will be about mainly about the intervention, about an aspect, whether the vascular part, whether it is cardiology, and part of it will be peripheral, and also including it as intervention for the venous disease as well. So actually, Dr. Labrish make my job is easier. So I will not go through it. I will go fast, as it's clear that it is a systemic disease that manifested, which will be going that the thrombotic effect affecting from the cerebral vessels, which is giving us pictures of the transient ischemic attack or giving the stroke picture. And whether it is going to the heart or this will be giving different manifestation, and this is clear that. Also, whether it is going affecting the aorta, whether even the wall of the aorta will be dilatation causing the aorta aneurysm, the manifestation. Going to the peripheral is showing the pictures of called that limb ischemia or claudicators, or even causing that gangrene and necrosis. From the WHO, that statistics has been brought that showing that that number one is cause of death is ischemic heart disease, and is responsible for about 17 million people death in 2011. Besides, it is a cardiovascular disease, and 7 of them that it will be ischemic, and 6.2 is related to the stroke, which will be number 2. Keeping in mind that also it was before 2000 and 2011, and even the expectation estimated also for further, even that showing that even for the coming years also will be these 2 diseases will be leading the cause of death in the internationally. Keeping in mind also that one of the 10 top cause of death is diabetes mellitus, which is showing here as it is aggravate also the cause of death, whether in the heart disease, ischemic heart disease, or in the stroke as well. So the diabetes also, it is silent, it's affecting these other disease as well. This as will be showing that changing what is happening in the concept of treatment, and this is intervention has been showed and make dramatic changes of treatment, dramatic change of these modules, dramatic changes in the outcome as well. And this has been a great effort and give great outcome in the hospital, especially with the hospitals will be loaded with affecting the vacancy availability in such our hospital. And this will be the modules which is will be listed, some of them, which is many modules nowadays coming for the cardiology, but some of them like angioplasty, thrombolysis therapy, or TAVI, and renal denervation, which is will be practiced. That which is I would like to just to share here this, which is will be the TAVI, which has been brought also, which is this is part of the one advantage is recently brought to the technique of treatment, that replacement of the heart valve with another artificial one without opening the chest and without patient staying in the ICU for about weeks or about more. This will be only percutaneous in the needle, and after that the patient after 2 days will go home. It is certain centers nowadays, they have developed such a technique and started to become invading many centers because of its advantage. I started with limited or restricted criteria can say it to establish such a technique, but it will in the future, as what happened to the peripheral artery, exactly intervention, it will happen also to the heart surgery as well, to be becoming less invasive, less morbidity and affecting the patient. And it is promising because of the results, what is outcome is coming, and what is the benefit getting for the community. And even one of the criteria which is restricted for the TAVI, which is transcatheter aortic valve replacement or implantation, is the elderly, which is it is a challenge for the medicine for treatment in the surgery as well. And this is only the needle will be puncture of the needle will go with the catheter to the calcified aortic valve, put it that artificial, simple as that, and come out, and there is no wound, no incision, and only will we keep the patient for observation, and even no need for keeping the patient in ICU as well. And high dependency is enough. And some of the procedures they want to do it as a local anesthesia, no need to be placed in general anesthesia as well. Also, that's one of the partings that will be started or launched also in our hospitals. This will be soon about renal denervation. This is part of the intervention for the resistant hypertension as well. And this will be promising as one of the modules of treatment for hypertension. Going to the peripheral is also, it's according to the pathology, which will be seen that whether peripheral, whether occlusion, aortal, as whether dilatation or occlusion as well, venous disease and carotid as well. This will be showing the modules of treatment. This has been shown that this is the thrombus, which is affecting the wall of the intima, and will be the migration of the thrombus causing the symptoms, which will be showing here. That patient is coming with the ulcer or non-healing ulcer or necrosis and gangrenous part, cold limb or pain. Mainly that's patients coming pain, but in diabetic patient, they don't have pain, so they are coming late for complaining about this symptoms. Only with developing his necrosis or gangrene, then it will be coming to be started to treatment. The modules of treatment for peripheral, it is very, it is almost a standard, whether it will be occlusion or narrowing. It can be treated simple of the guide wire and that ballooning, or even attack to the certain. And going to a little bit the major vessels of the aorta, also there's aneurysmatic changes that nowadays is replaced with this stent graft only to keep it in the aorta, and that's it. Also the same advantage as I mentioned in the TAVI, the patient, this will be done under local anesthesia, no need of general anesthesia, no need of the long duration of the ICU, short period, patient after 2-3 days will be going home. And even nowadays it started to for the rupturing side as well. At the beginning, it was started at the trial base. Now it is also started to become also for the rupturing aorta is becoming a standard. It is not yet, but it will become in the future. It's coming promising, life-saving for such a candidate, which was mortality is more than 90%. Even for going for thoracic, which is happening with the thoracic, whether it's aneurysmatic or it's a dissection during car accident, has been also established that this technique as well saving their lives. Going to the venous, which is a little bit far away about cardiovascular part. About this is also the venous, which is also the modules of treatment with laser or radiofrequency, which is promising also as well as it is outpatient. Is no more patient will be admitted to the hospital. The patient the same day go home, and next day he can go to work. Going to the endoneurovascular therapy, which is the modules of treatment, has been introduced. It will be whether it will be for it causing the stroke or transischemic attack, with modules whether there will be thrombolysis, thrombolectomy, and also the stenting or ballooning. And this before it was like treated these cases for carotid as endarterectomy, removal of the plug. It started to become lessing number because of it is getting more popularity between the community, and it started to become demanding there because still there is a surgical intervention for that, but still the community or the advantage for it because of the challenges of some cases can be treated with this intervention technique by ballooning and stent implantation. The pathology for the cerebral vascular disease as anomalies, whether it is aneurysmatic, as it is here to finding, is showing that also can be treated by the tip of the needle technology as putting of the stent graft, and which will be can controlled here. This will be abolished, and also this case is no need to open the skull and to ligate or to dissect that portion. Only this is only stent graft and guide wire, and that's it. Isn't if going about the malformation, the arteriovenous malformation in the brain, the same technique as well, whether the coiling technique or the embolization. This concept has been also that before, as I mentioned it in UAE or in Dubai especially, that will be against us to start it as thrombolysis therapy for the stroke. Because of the studies, because of a lot of good results have been implemented internationally, has been implemented recently also, and we are giving good numbers for that, treating whether because of time frame about 3 hours to saving these cases, that because the patient will be coming later than 3 hours, it is to save these cases, it will be almost less, optimal outcome. By this thrombolysis or by thrombectomy for the cerebral vessels also, this will be saving a lot of cases made from the developing any handicap or chronic bedridden cases. It is noticed that the vascular diseases will be increasing by the aging population, and it is epidemic, and associated with others, diabetic mellitus, obesity, hypertension, and renal failure. If going to speaking about the diabetes, also this with vascular, the peripheral artery disease is 5 times more common in the patient with diabetes. 30% of patients with diabetes have peripheral arterial disease. The major limb amputations is 4 times higher than with diabetes and peripheral arterial disease than with arterial disease alone. That some references like from the critical about limb ischemia and about the claudicators, that approximately about 401 million per year has been noticed from the link ischemia, this affecting the outcome of result of the vascular disease. Approximately from the 500 to 1,000 in 1 million about 1 year is critical limb ischemia. Real-world snapshot as Medicare database from 1999 to 2001, that's 2.5 million from these cases as critical limb ischemia is going for 417 amputations with no previous history diagnosis, 49 of them with the patient. Approach of that, the aim of that to reach for the critical limb ischemia or for the limb affecting the occlusion of the vessels, the endpoint is to relieve the pain, because this is critical part, or non-healing ulcer to achieve the healing of the ulcer, or improve the quality of life. This will be as what is the pictures we're showing, and the techniques reaching. This is mainly before it started for big vessels. Now it is reaching till the tip of the fingers, is even the ankle level, the improving of circulation. So it's no more the history that only taking the big vessels improvement circulation, also till the distal part, till the tip of the fingers, improving of circulation. This here showing that is exactly that patient with going on amputation is the expectation of the life is about 50%. So that the morbidity will increase by improving the circulation in his limb, which is affecting his outcome for the living. This is the distal part. As for that stenosis, one of the elderly patients, the modules of treatment is changed, is not only that ballooning and stenting now, since laser has been introduced, or with the thrombectomy and removal of the plaque or removal of the thrombus. Going to the GCC's place countries, which is what is known as clear, is about 6 countries: Saudi Arabia, Kuwait, Bahrain, Qatar, Emirates, and Oman. Then the population, which will be showing here, is about 7.8 million, growing from 2010 39.2 millions, which is expecting about 2050 65.6 millions. By this growth, we have to be taking how from them they are involved in the diabetes. The GCC among top 10 countries in the world, and this should be considered prevalence in the UAE to 24%, may increase 40 to 50% by 2020. Going to that, slowly to the UAE, about estimated population is 8 million, and it will be increased to 2010 to 8.2 million, and expecting that to be having the last studies also, which is not yet received in 2014, which will be increasing as well the numbers. So Dubai's Emirates, one of the showing increasing of the population, and expecting also to be increased dramatically also the number of population from 2003 from 1.04 to reaching about 2013 2.2 million. Now which will be more focusing now to the hospital, which is practicing our for the cardiovascular cases, as this is a Rashid hospital. Rashid is one of the Dubai Health Authority hospital, one of the 4th hospital. It is a tertiary care acute hospital for trauma and for acute other cases like cardiology, infectious, or the diabetes or endocrinology as well. Then it has been attached to it a new expansion 2006, which is from trauma centers, and the expectation to building the new center, which is showing that one. Will be coming soon. That like Rashid City Medical City, inshallah, will coming soon. That because it will be overcome of the population number. Started Rashid Hospital 1973 with almost 250 beds, increased to in 2007 to 390 beds, and reaching now 2012. Although of the increasing expansion of the department and the bed, but still we have challenges. The waiting patient for admission, it is increasing year by year. Although we have an expansion, but it seems it is multifactorial, affecting that number of the admitted cases, because the strategy has been changed in the hospital to share other facilities for admitting or to receive or continue the care with them. The length of the stay is by the introduction of the intervention technique has been reduced from 10.2 days to 9.11. Mainly it is being shown clearly later on in the cardiology department, one of the active department, and it is very active in technology, in admission, and in the modules of treatment they are offering for our patients. Shown that from our statistics that myocardial infarction, and it's received in the hospital, the second top diagnosis, the third top admission and discharge in the hospital, and the first top 10 procedures performed for these cases especially in the MI. Length of stay has been reduced from 8.36 till, for in 2013, 4.68. Accredited hospital, this is cardiology department speech disease from JCI 2000, this is for second accreditation, and Rashid Hospital itself also accredited by the JCI as well. The numbers I just collected because of from the new cath labs, I collect these two data, it is, short, 2 years only, but it is showing only having the pictures about the number of cases for 504 to 527. This is because of the sharing of other centers for us, for supporting us for whether to be taking transferring of the case or sharing about the treatment as well. Door to needles will be achieved. Door to needle is a 23-24, which is versus an international, it is less than 30 minutes. Door to balloon is 74 minutes, less than internationally 90 minutes. Speaking about the TAVI, it is a group and multi-specialty. The group, it is including of course, the main team is the cardiology, but also it's sharing with the vascular team, anesthetic and intervention radiology is as well. It's also, this is one of the examples has been practiced last week. It's been implemented for one of the patients. Just put it in the needle, and the balloon, and after that, putting this implanting of this valve, and the patient, after a couple of days, kept in the high dependency. After that, is going home. Other part of cardiology, it is about hybrid OT, which is mainly it is for the invasive vascular intervention. Majority of the cases done under local, and which is started 2009, including these hybrid, what is the procedures with the aorta, peripheral, venous, carotid, neurovascular, or other miscellaneous. This is only showing numbers, the numbers which is here. It is just the volume which is for the just started and 2013, expecting to increase the cases as long as we are establishing the short stay or the as outpatient patients coming and going the same day for the procedures which will be performed for them. This is an example, pre and post for the occlusion, or this is not one of the gangrenous cases will coming, and if it's seeing that it is the ankle region, which will be, the other one is going that for how still, which level we are reaching till the ankle joint and below as well. And it's
so we have 2 minutes.
For the elderly. Yes.
2 miness.
Inshallah. So I'm coming the final
concluding anyways. Yes.
So there is other cases for the angioplasty, as carotid, occlusion. This is 2 days back done for the occlusion of the internal carotid. This is done on Sunday. And this is total vascularization for carotid. The patient is kept in the high dependency. Now the patient is walking. As aorta's procedures will endograft assessment as well. Also, this is for the traumatic thoracic and cerebral aneurysm, and this is for the venous disease. And come to the conclusion, it has been noticed that continued growth in the population in our community, growth in aging population, and the increase in nutrition health problem and cardiovascular disease, and it is has been noticed. Similar, this will be happen in the Western, and it is showing statistics from Dr. Kenneth as well. Endovascular procedures are shown to become a treatment of choice for the outpatient, and in particular with shorter situation. Endovascular phase strategy of peripheral vessel should be considered in majority of patients, and especially in elderly and patients with severe comorbidity. And I hope we reach that level. Thank you very much.
Thank you very much, Dr. Kazem. We would like to move on to the panel discussion, and let me briefly introduce to you our panelists in addition to our two speakers. Dr. Lionel Jarvis is the Chief Executive and Medical Director of Heart Hospital and Hamad Medical Corporation in Qatar. Dr. Jarvis spent his early years as a physician in the Royal Navy, both at sea and shore around the world. He trained in internal medicine and radiology. His special interests were in musculoskeletal and interventional radiology, and he had lots of research and publication in this area. He had won prestigious awards in RCR Traveling Fellowship in 1995, and some other prize, the Errol Eldridge Prize in 1998 in UK Diagnostic Imaging Doctor of the Year, an elective member of the Institute of Engineering and Technology. He also has an impressive background on with the UK Armed Forces. He was deployed as operational activity in a number of conflict areas. He has a big interest in the area of global public health and climate change. He was appointed as Honorary Surgeon of Her Majesty the Queen in 2006. So he brings to us an interesting background from medical and military. And I'm trying to relate that a number of challenges that we have in our population does, I feel, indeed requires a background of interventions that could work for the mass movement. We also have another panelist, Professor Ahmed Al-Blushi. He's a senior consultant cardiothoracic surgeon, fellow member of the Australian Society of Cardiac and Thoracic Surgery, European Society for Cardiovascular Surgery, Scandinavian Society of Research in Cardiothoracic Surgery. He has an extensive background on teaching and research. He used to be professor of anatomy and embryology, where he is currently in Oman Medical College, and a formal tutor of the anatomy at the Royal College of Surgeons in Ireland, research and clinical fellow and clinical teacher, postgraduate and undergraduate study at University of Glasgow. He held positions within the research and also the quality assurance and audit committees within his health system. The third is my colleague, Dr. Wa'el Al-Mahmeed. He is consultant cardiologist, head of cardiology division at Sheikh Khalifa Medical City, part of Abu Dhabi Health Services Company, SAHA. Dr. Al-Mahmeed did his medical school at the University of Southampton. He went further to specialize in internal medicine, cardiology, and echocardiography at the University of British Columbia, Vancouver. He played a number of leadership roles within our health system in Abu Dhabi here. Under his leadership, a number of prestigious international meetings were held and about to be held in Abu Dhabi. He was instrumental in expanding and propagating our medical education, and he continues to play a leadership role in a number of other relevant areas. So as I open it for the discussion amongst the panel, I'm thinking to have our panelists reflect on the two talks. As you can see with me, that we had a broad population talk in which a number of interventions were used to apply to a population, leveraging electronic health record, leveraging population statistics, and piloting some interventions and then expanding it. Further, the second talk was about interventions that helped individuals. So many surgical procedures were abandoned because we developed interventional procedures to replace them. So this helped many patients. However, tying this all together, how could we, if we have a tsunami waiting to happen in terms of the population aging, the chronic diseases proceeding. Not too long ago, there was a non-communicable disease with participation of the WHO in Dubai 2 weeks ago. And one of the key targets, difficult to achieve, was put forward about if we needed to make a major impact, was to target the goal of zero increase in diabetes in this region, in this population. How could we do that? And I could also have a final comment before I open it, that UAE, the government of UAE has recently announced to have a military service for those who finish high school 9 months and those below their secondary school 2 years. Could we have a health care or health curriculum to help impact the population behavior? And could we study this? Could we use it to see if an intervention could be introduced this way? So without further ado, I would like to open it up first for Professor Jarvis to perhaps reflect on the two talks and maybe add some comments, and then we'll move on to Dr. Al-Blushi and Dr. Wa'el, and then hopefully we finish on time and open for some questions.
Thank you very much, and thank you so much for your invitation to join you here today to ECSSR and to RTI. Fascinating morning of introductory speeches on this challenge of this, as you say, tsunami tidal wave of cardiovascular disease that is approaching this region. And if I just add one statistic, if I may, that of the McKinsey report in 2008, projecting in the GCC states a 240% increase in disease burden up to 2025, 240% average, but 419% for cardiovascular disease. That disease is coming, it's hitting us, and we know that it's on its way. So the question I think we have, which combines nicely these two talks, is how do we manage that current imminent disease burden within the confined resources that we have, and how do we prevent it hitting the next generation? And of course, the second talk on all of the interventional procedures elegantly demonstrates that with newer scientific methods, intravascular procedures, stenting, percutaneous angioplasty, we can actually reduce length of stay, reduce further morbidity, and reduce the long-term burden on the state. So the investment in the region in introducing these technologies, education and training, but also in the research and development that takes these procedures to the next stage, is the approach that can actually bring us some degree of control of the burden that faces us. And that, of course, is opposed to the other issue of how to prevent it for the next generation. And I'll just build, if I may, on one component of the preventive medicine strategy with abundant evidence that demonstrates that if you target the preventive strategies on a population, as has been described, controlling diet, smoking, exercise, health checks, you do have a tendency to increase the disease inequality across an organization, state, or nation. Those who benefit most from these interventions are those in the higher socioeconomic groups. Those who benefit least are in the lower socioeconomic groups. So you widen the inequality. Whilst there is a huge benefit to society as a whole, the evidence shows us that the interventions that impact upon the whole population are those statewide, affecting taxation, legislation, and so forth, which I know the UAE is introducing at the same time. But it's important to recognize, as many do in this room, I'm sure, the differences in these approaches that can look at both the global population and avoid the stretching of inequality as we look to the next generation, and hope that today's children in the UAE and the Gulf states do not have the burden of disease that we have for the current generation. Thank you.
Thank you. If I could follow up, we, with some colleagues, have discussed that the military schools, for example, they have more rigorous curriculum on health, on healthy behavior, on diet. Perhaps there is a selection bias, but at the same time, I think we all see that perhaps with some interventions that were instituted early on resulted in some impact. How do you see a government that is flexible to do what it takes for the population? How do you see the interface between the medical community, the government, the legislation, in impacting population behavior, and what opportunities do you see for this region?
It's a contentious issue, but in my opinion, there's actually no doubt that putting young men and women at a certain age when they are impressionable through a period of time in which they have to be fit can change their motivation and approach to their level of fitness through later life. If during their childhood they have become accustomed to sitting around unhealthy, then they need a kick at some stage to change their behaviors for the rest of their lives. And we've certainly seen in the Western population, sadly, that the tendency towards sitting around watching television and playing computer games rather than being out on the football field is producing fat, unhealthy children. We need to change that and bring a time of life in which they can refresh their approach to their health.
Thank you. Dr. Al-Balushi, you heard the two talks, and do you have some comments, given your background in education, research, and your profession, about us having some interventions that hopefully works in this community?
Thank you very much. Actually, I noticed from the discussion, I have a couple of points I want to clarify.
Please.
First of all, we talked about the intervention. Some criteria or some risk factors, I think whatever we do, it's a bit difficult. We have to be a bit realistic in changing them, like non-modifiable risk factors. These are difficult to change. For example, the genetics, the race, the age, they are the main bulk of the problem. The other thing is the new interventions, like reducing the effect of a couple of subtype of risk factors, which is not mentioned at all, I think, and it is very important. Now, I remember these prevention lines or pathways started in the 1950s, and Professor Labrish, I think, an expert about these kind of guidelines. But we have 5 bodies of expert kind of institute that put in guidelines. We have the World WHO, the American Heart Association, American Stroke Association, and name it. We have 5 bodies. They have their own guidelines. European they have their own guidelines. Again, they are talking about the same preventive measures, which is implied, like I remember from, if you follow them from 80s, 90s, and 2012 or 13, the last one. The only one I think is practical for time being, which is do we have a risk stratification? We have scoring system. We don't have scoring system, very good scoring system. We don't have a very good risk stratification system. And the most important thing is the new techniques. Now, what Dr. Yunus presented here, this is the management. It's a management. It's a surgical intervention for already what happened. Like, and there's no surgical prevention method, which is there in some places. But again, it is not recognized by the, I would say, FDAs or the scientific institutes. You have some procedure in areas like China. They do a lot of things which is really preventive. Well, we don't have them here. The other important factor, actually, I think it's the Professor Labrish mentioned, is about the children education. Now, if we can compete with the
video games,
yeah, the what they call it, I mean, you cannot ask a child or relatives, even the parents, to sit and look at the internet or to see these programs and to shift the children and the teenagers' direction or thinking from these games. It needs really, we have to have a powerful tool to shift, to create that shift, because the game industry, the food industry, the cigarette industry, name it, they are so powerful, really powerful, that no matter we do, and it's millions. I remember the last, in 2009, in America, it's American budget, they spent $444 billion for 1 year to prevent not prevent, it's a managemental procedure. Now, if you want to imply the preventive methods, yeah, for modifiable, we can, but non-modifiable, it's difficult. Modifiable, we have to be really serious about it, because we have companies like, again, cigarette, games, food, you have to compete with. It's not it's not a gloomy picture, but that's the truth. So either we put policies, really, really good policies, and people dedicated to do the job, and they are really there to do the job, nothing else. Well, we have a lot of guidelines, maybe more than 130 points in each guidelines. Some of them applicable, and the other are just fitting the gaps, I think. But in practice, in the real world, we need...
Thank you. I think, this was also captured by the WHO, and they said lots of negative messages or the impacts from media or from variety of perhaps it's unintentional or it's unopposed. So at a population level, governments have to take serious measures. And also part of it, to just reflect on the title for this conference, is to reflect on perhaps systematic ways of funding research in this region to answer these questions, because evidence show that when it's a general guideline issued by whatever society, the tendency to comply is way down, lower than if it was customized within a health system or a hospital. So lots of need for to tailor research into studying what works in this community. Dr. Wael, given your expertise in working with societies in the area of education, research, what's your reflection on the topic of us seeing increasing numbers of cardiovascular diseases and stroke? And how do you see this changing if we change the way we approach education in this community? Thank you.
Thank you very much. As most of the panelists have said, we have a big problem here. Just last night I was reading a Booz Allen report on the burden of non-communicable diseases in the Gulf. They predict that the cost in 2020 will be $30 billion for all the Gulf states. And the cost right now is $30 billion if they were to act now. And by 2020, it will go up to $68 billion if they don't do anything about it. So this is the burden of non-communicable diseases in the Gulf states. As you know, I'll just make a very short comment. Basically, it's time to implement and act. We've had many talks, we've had a number of research, we've had a lot of education, a lot of meetings like this, people coming from the WHO, from colleges, guidelines, strategies have been put forward by different bodies, but I think it's time really to implement any one of these strategies or all of these strategies. Something has to be done in terms on the ground, and I think this is what we're lacking at the moment, is a coordinated action plan. And it has to involve all the stakeholders. It just doesn't include us physicians, it includes education, health, ministries of the religious affairs, media, and it has to be totally coordinated, and then it has to be monitored. Where are we going? Are we doing the right thing or not? But I think the time has come really to coordinate all these actions, all these research and all these ideas that we have and put them into implementation. And I think right now we're all doing little small things and it's all fragmented. We have to try and put it together.
Thank you, Dr. Wael. I think as we heard this morning, the political will is there, so it's among us. It's a next level, at least in this part of the world. The political will from our political leadership, the support is there, but it's for the technical people within different jurisdictions, because as you say, the social determinants of health goes way beyond what is delivered in a hospital or a hospital setting to impact population's health. And we need to define it better in our own technical words, and then put perhaps a joint recommendation to the authorities. And we are lucky to have Professor Tawfiq Khoja, who represents the healthcare ministries within GCC. So the political will and support is there, and he's always been supportive of, if we as technical put our heads together and agree on a common statement or a joint statement, whether it's about optimizing research funding or having a recommendation that resonates well and it's well thought of, that we've always seen it make at least its way to implementation. Let me go back to Professor Labrash. You highlighted the powerful impact of electronic health record in changing the way we practice. And we see this region in UAE and the rest of the GCC heavily moving towards health information system to become paperless. We also know that recently in the States, the American Board of Medical Specialties included medical informatics as a formal recognized specialty. And you also highlighted how could we leverage board recertification with courses on quality assurance. How do you see this region benefiting from this and trying to be the early adapters of health information system, not the connectivity piece, but the usability and implementing some quality assurance, some population health aspects to make progress in this region?
Well, I think that's an excellent question. We are really in the midst in the U.S. of a major upsurge in the use of electronic health records, generated by a concerted effort on the part of government and creating meaningful use criteria so that physicians were provided financial incentives to use electronic health records and use them effectively. So one of the examples that I gave you was a very simple handheld tool to help calculate blood pressure percentiles, a decision support tool. Electronic health records have decision support built into the system, and so it simplifies the ability to use the information because it's only put in once, and then it can be used to provide at the point of care the recommendations that are pertinent to that patient at that moment. And so there are a number of components. I think their government could certainly be most helpful. Electronic health exchange is an important component, so that if a patient is seen in a primary care office, then perhaps hospitalized, then seen by a subspecialist, all of that information is available via a central exchange mechanism. That becomes really important. One of our problems is that we tend to duplicate a lot of activities. So we'll do a test, we don't have access to, the next physician may not have access to it, and so they repeat it, so it becomes very expensive and care becomes very fragmented. So because of that, I think there are a lot of incentives to provide incentives on a central basis. And I think one of those areas is in exchange, and one of those areas is in the economics of adopting electronic health records. I think you'll want to think about some standardization. Right now, standardization is a bit wanting among the various vendors that sell electronic health records to ensure that they can communicate effectively with each other, to incorporate testing into an information strategy. Will be an important part of all of this as well. We saw some lovely pictures from revascularization. To have those available in the primary care physician's office so they know exactly what has occurred is a way to be able to integrate all of these systems and get everyone functioning on the same page. So I think it's an important component, but just one thing I would leave you with is the notion that no matter how many resources any country has, we can't treat ourselves out of this epidemic of cardiovascular disease and stroke. There aren't enough resources to be able to treat every patient. And so putting more emphasis on prevention, more emphasis on primary care, and I say this as an interventional cardiologist, I've been there and done those things, but I think that we need to have a much more important role on the part of primary care physicians, and electronic health records will certainly help facilitate that.
Thank you. I think we have time for a few questions, perhaps 2 or 3. So any comments, questions from the audience? Professor Tawfiq, and then, yeah.
Bismillah ar-Rahman ar-Rahim. Thank you so much for this excellent presentation and the way you run this session very effectively. And I think this is a very excellent ignition of the whole conference. And really, I admire the presentation from His Excellency, the Sheikh, which really put the way forward and also summarized most of the activities which has been done in the GCC in the last 10 years. I would like to correlate or to reflect the presentation on the theme of the conference. It is the public health. I discussed with my colleague, Dr. Mahmoud Fikri, and really, Dr. Kadhim, this is a very excellent presentation and encouraging us that I have 7 stents in my heart, by the way. so this is encouraging to see such approaches. But I am a family physician. I am a primary healthcare person. I am a public health person. And I look to Professor Kenneth's presentation. Studies evidence shows that adoption of the guideline in the hospital base is 1 year. People they are going to the guidelines very quick to 1 year and then gradually fade if there is no follow-up and performance measurement. In the primary healthcare, studies, especially in UK and Oxford, I am a British-oriented person. I graduate from UK. So they found that only 35% in the primary healthcare, they adopted the guideline. My question actually, what you have said is very evidence, it is clear that adoption of the guideline help a lot in improving the quality at the hospital level. But here we are speaking about the public health issue. We are speaking about behavior. We are speaking about health determinants, social. I would like to have a comment from your side. Do guidelines in the primary healthcare setting or in the public health setting help, or there is another atmosphere we have to work in with the guideline? Thank you so much.
Thank you.
Well, I think you make an excellent point. One of the reasons we try to emphasize secondary prevention is that what we would call the low-hanging fruit. So someone who's already had a heart attack or a stroke is at very high risk for a second event, and so that's a starting point. But in the end, we really need to impact the vast number of folks that are destined to have these diseases. Primary care physicians can be very helpful because they become the guide to healthy living in an ideal world. What they advise needs to be possible. And so if I advise exercise and there's no good place for my children to play, for me to go for a walk, you can advise all you want, but you have to have the infrastructure to be able to do that. So, designing pathways. I know you have your Corniche here, which is a wonderful walking path or running place. But having facilities in the public sphere that allow patients to get regular exercise. Re-examining the food supply. And do we make available vegetables, fruit, the sorts of things that we would like to have our population consuming? We were having a discussion beforehand. We see the influx, sadly often from my country, of fast foods. My particular pet peeve right now is Kentucky Fried Chicken, which I see. I don't know if it's invaded here yet. I've been spending some time in China. And that's become, for the children, for the adolescents, one of their favorite places to eat. And as a cardiologist, it gives me pain to think about that. And so from a public policy point of view, what are the things that can be done to make access to healthy foods a bit easier, to make exercise in the school systems? In the U.S., physical education is one of those things that seems to be de-emphasized over time. I think that's a real problem. And so I think if we sort of line up those kinds of activities that we would like to see our children and our adults pursuing, and then line up public policy to support those, we'll end up with a much healthier population, and we'll end up spending a lot less money on healthcare.
Thank you. I think we have 2 last questions.
شكرا دكتور. Thank you, Dr. Obeidli. First of all, let me extend my appreciation to the Emirates Center for Strategic Studies and Research for this invitation and for holding the first really seminar or conference on health. And we wish that to extend our request to make it on a periodic, public health, and make it a periodic meeting, annual periodic meeting maybe. So, my name is sorry, I didn't introduce myself. My name is Dr. Mariam Al-Jalahma. I am the Assistant Undersecretary for Primary Care and Public Health, background family physician, and my job is to keep hospitals free of patients with cardiovascular complications. I hope we can reach to that stage. Well, anyway, I think thank you for the wonderful presentation and to see the advances in technology and also to look into application of guidelines. I feel, from our observation, we find that primary healthcare physicians are more committed to implementing guidelines. Where we go to hospital, we find physicians apply their own guidelines. It depends on where they graduated from or where they got the practice from, unless national guidelines are enforced. Anyway, what I want to say is going back to basics, as Dr. Wael said, let's work on prevention. What I want to say is that the kings and leaders of the GCC countries has already approved the unified GCC plan for prevention and control of NCD. And this year in Kuwait, we had a ministerial meeting, and they approved the updated NCD plan. It's already there with WHO indicators, updated ones that are going to be reported to the United Nations. We have the baseline. We have one GCC plan. All we need now to do is to do it or convert it into national implementation plan for each country according to their situation. So I think this is very important, because if we put plans and we don't implement them, we don't monitor them, then what's the use? The plan incorporates best buys, as you said. I think we should focus on the laws and regulations of anti-tobacco, healthier food, places for exercise, and implementing and enforcing the law, like preventing the trans fats in foods, either manufactured or imported, or looking into the decrease of salt in the manufactured food also. All this is in the plan, and we are most welcome to share it with you. Thank you.
Thank you for your comments. I think if you pass on to your,
Thank you, Dr. Ali. First of all, I would like to thank our eminent speakers, and actually I'm also a family physician. My comment is regarding to Dr. Kenneth Labrish. Actually, in your presentation, Doctor, you mentioned that cardiovascular risk starts from childhood, and I agree with you. And regarding this comment, I have another comment. Actually, in our GCC countries, the life expectancy at birth increased during the last 30 years dramatically, from around 45 to 50 years old, 50 years. Now it's more than 75. And I'm afraid that this trend will not continue if we don't interfere. Actually, what we are measuring now is the life expectancy and the mortality rates of generations that were not affected by fast foods. McDonald's and the other fast foods were not affected by the video games. Most of our exercise and habits were doing exercise outdoors, which is not now the habit for our children. So do you think that we will face the tsunami that our colleagues mentioned is already coming, and we cannot do anything regarding it, since our children is already obese, they are not doing any exercise, and we will measure their life expectancy during the next 10 or 20 years? Or we should be optimistic, and there are solutions. I don't know what's your experience in the United States and other countries, and your expectations in our region. Thank you very much.
Well, first of all, I totally agree with you about the life expectancy issue. There was an editorial in the New England Journal of Medicine in 2011 that made exactly that point, that in the United States, this current generation of children will be the first generation in the history of our country that is expected to have a lower life expectancy than the preceding generation. So generation after generation, our life expectancy has been increasing, and that is now at great risk. So one of the things that we've really been working on a lot is biking trails. We have a whole network in New England now, the part of the world that I live in, of walking trails, and so it becomes a little bit easier for families to go out. And one of the things that I enjoy when I'm there is seeing whole families biking, walking, and having exercise. I think one of the interesting developments from a technology point of view is that some of the game consoles now have exercise games built into them. And so you can play tennis in front of the TV, you can do all these things. I'd much rather have children out on the playground as we were when we were children. That doesn't seem to be happening, and I'm not sure that there's a lot that we can do about that right now. But some of the technology that involves some of these, dancing, aerobics, playing tennis, all these sorts of things, combines the screen time, which we'd like to eliminate, but actually is able to convert it to more of a force for good than for evil, if you will. And so perhaps we will find some technology solutions that will help us, which are ironically the same things that are causing some of these problems in the first place. So I remain somewhat optimistic, but we certainly need to take action. And of course, a lot of the burden here is in the ballpark of the primary care physician. Family physicians will have a great impact on this. And so the more that we can do to help improve the role of family physicians, pediatricians, the better off we will all be in the end. And I could go on about reimbursement in our country. Primary care physicians are grossly under reimbursed for what they do compared to the likes of me, a cardiologist who puts catheters into people. I think that has to change.
Well, thank you. I think it seems our time is up and we're expected back in this room at 1:30. I do encourage you for direct interface with our panelists and speakers and use this, the rest of this forum for more interactions. Thank you very much.
Bismillah ar-Rahman ar-Rahim.
In the name of God, the most gracious, the most merciful. Peace be upon you all. In the beginning, I would like to thank the Emirates Center for Strategic Studies and Research to invite me and to organize this great event, the RTI.
I would like to start by convening the panel, number 2, on the economics of obesity. But the first thing that comes to mind, why this topic, and of course this whole conference is about that. And we all know that there are many estimates that show that the prevalence of obesity and related health conditions is at an alarming rate in the region. And without even giving the numbers, whether it is 30%, 40%, whatever, the consensus is the GCC country rank among the top in terms of prevalence of obesity, which points to a serious problem. More serious also is the creeping number among the young people, which means we are embarking on a new generation that will have a lot of causes of morbidity and mortality. The causes for this are multiple, and then they, beside the genetics, then you have the overconsumption of high calorie-dense food, the emergence of fast food or convenience food. And somebody was asking, is there a KFC here? And the answer is yes, and there is, and they deliver to your door as well. So that is the case. We have also the environmental issue, where the weather is hot. It does not help in terms of exercise. And the urbanization is very fast, which also was not accompanied by sufficient walking trails and things for physical activity. And then you have also the inactivity, where everybody is using a car, and even at home, you have personnel that does a lot of the house chores that somebody could have used, at least for minimum exercise. Add to that the income level that really lead to sometimes indulgence in whatever we can afford it, we can indulge in it. And the family and peer influence in our culture here. Every event is around food, and certainly today is not an exception to that rule. So the result of that is the unhealthy eating combined, which is a high energy, combined with the culture of food-centered activities, which lead to higher energy intake. There is the environment does not help. The surrounding also does not allow you to expend a lot of calories, which means that will be stored somewhere, and that's why we have an increase in waistline. So that double impact is something that we need to do something about it. And in terms of consequences, we all know that the issue will reduce the quality of life of the individual due to poor health. And there is also the high healthcare expenditure, both of the individual and the country, and the reduced overall productivity due to that. Given all of this, we know that the problem is multifaceted, and therefore it requires a concerted effort that touches on so many angles at one time. That includes prevention, intervention as early as possible, especially at the childhood level. That will include understanding the connection between the genetics and the lifestyle and the environmental interaction. That include the socioeconomics and policy angle, the social and behavioral aspect, the awareness campaigns in the media to increase the level of awareness, and then also preventive care as a major component of the national healthcare system. So today we will hear from some of the prominent researchers in the field about some of these aspects in the form of 2 presentations, followed by a panel that will sum it up and cap it and allow us to have a good discussion. The first presenter is Jean Weicha from RTI International, and her presentation will be Research to Action in Obesity and Chronic Disease Prevention. And this is certainly a focus on an integrated intervention that involves community engagement, and certainly a part of that multifaceted approach that is sorely needed in terms of stemming the rise of obesity. So without further ado, please help me in welcoming Jean Weicha. I'm sorry, I think there is a little bit of mishap here. That is, I'm supposed to go through a little bit about Jean Weicha's background. Jean is nationally known for her work in childhood obesity, with 25 years of research and leadership in community, academia, and state government. Her area of expertise is specialization in designing, evaluating intervention for promoting and assessing physical activity and nutrition, with the focus on community-based participatory research. She's a co-founder and chair of the Healthy Out of School Time Coalition, and then she has been very effective in developing, disseminating these kind of programs and standards. Her work has been funded by many organizations, including the Wood Johnson Foundation, the Center for Disease Control and Prevention, the Harvard Pilgrim Healthcare Foundation, and the Walmart Foundation. She certainly has been very active in this area and a well-known expert to her own right. Thank you.
Good afternoon. Welcome back from lunch. I'm going to depart a bit from the earlier speakers, and I'm not actually going to present any data. I'm not going to talk about studies per se. I'm going to talk specifically about the process of moving research into action in the areas of obesity and chronic disease prevention. It's really a pleasure to be here. This is my first visit here, and I'm just enjoying the city so much and the warm welcome I've gotten, so thank you. So I'm going to jump right into my next slide and allow you to look at this for a moment while I speak a bit. I'm going to talk today, I'm going to tell you a story about this project, this body of work I've been engaged in. I'm a health promotion scientist and a nutritionist by training. My work now, though, is really about this bridge that Dr. Labreche talked about between science and action, and how do we cross over that bridge. So I've been working really closely with non-governmental organizations, NGOs, and nonprofits in the US to do translation work to help children eat healthier and be more physically active to prevent and manage obesity. So I've been doing this for a long time, and this particular project is it's been a wonderful adventure for a group of us. So I'm going to talk today about obesity. I'm going to set up some epidemiology for you quickly. And this story is set in what we call out of school time, so I want to be clear what that is. In the US, when kids get out of school, typically they have a number of hours before the end of the day, and many kids, about 15% of American children, go to what we call an after-school program, and they spend several hours there. They may also go to a program before school, so particularly if the parents work, the kids may get dropped off before school and not picked up again until 6 p.m. So we have a lot of nonprofits that run programs for kids. And they've been doing this for many, many years, but only in the past few years have they really turned their attention to using the out-of-school time, or OST as I'll call it sometimes, the out-of-school time setting, to prevent obesity. This gets at comments that people have been making throughout the day about the interdisciplinary and environmental nature of how we can go about preventing and managing obesity. So I'll be talking to you about the out-of-school time setting and what we've done to use it, to leverage it, to promote healthy eating and physical activity in kids. So I work very closely with an NGO called Alliance for a Healthier Generation, which was started by President Clinton a number of years ago, and is the largest NGO that's focused exclusively on childhood obesity in the US, has a very big presence in all 50 states. And just a week ago, President Clinton announced the expansion of an initiative that I've been working on in its pilot stages to promote healthy eating and physical activity in out-of-school time. And so the story is that 5 years ago, 4 of us were sitting around in a room thinking, you know, there really must be a way that we can use the out-of-school time setting to be part of the solution to the obesity epidemic. That was 5 years ago. In this announcement last week, President Clinton talked about expanding the Alliance for a Healthier Generation's work so that it will soon impact 4 million children in about 4,000 after-school sites. So we're really excited about the growth of this movement, and what I want to do in this presentation is tell you that story. Just briefly, I've been the evaluator for the Healthy Out of School Time Initiative and Alliance for a Healthier Generation. This has been my connection with them recently, but I've been with them on this journey as they designed it as well. And I'll talk a little bit more about the project later, but this is obviously a graphic of the United States, and the project is currently in eight communities in 4 states. And we're soon to build it out. This is a little press piece that the Alliance put out, and I'm so tickled I got to be the quote and got a nice plug-in for RTI there, so I thought I'd show that to you. So the out-of-school time setting, again, often takes place at schools, in the schoolyard, and this is just a picture of some kids. And what we were trying to do in our project was show that we can use this setting for healthy eating and physical activity. And before we started, people didn't think about it that way. Often when I would talk to people who worked in out-of-school time, we'd ask them about the snacks they'd serve, they'd say, you know, this is kids' time to have fun, so we don't really tell them what to eat or anything special. We just give them some cookies and, you know, maybe we'll do a little homework support with them. And we've really tried to change that picture and say, no, this is an opportunity for all of us as adults to change the environments that our kids spend time in and use them to promote good health. As I'm speaking, I'm hoping that you start to jot down questions about how some of what I'm going to convey about the frameworks we work in may be relevant in this region, and I'd be happy to talk to any of you later or throughout my visit here. So I want to be really clear, first of all, about some of the definitions. In my talk, I'm going to be focusing on the term obesity, and want to be clear that I'm talking about a body mass index at or above 30 for adults, and at or above the 95th percentile on the CDC growth charts for children. So in addition, I'll be talking about chronic disease, and of course, these are the non-communicable chronic diseases. You know, we worry about obesity and chronic disease for a number of reasons. But one of the reasons that we group them together from a public health standpoint, obviously, is that they share common roots in terms of behavioral factors that promote them and that we can intervene on. So as was just mentioned, obesity and chronic disease are a result of an interaction of behavior with genes and environment. But as public health professionals, we can push those behaviors in directions that we want if we can design good interventions and if we can get those interventions to stick, and that's that translation piece. We worry about obesity for a number of reasons, of course, and cost is one of them. So work that was done by RTI scientists a few years ago clearly demonstrated that in the US, this is a really expensive epidemic, and this is just one study and one set of analyses. We count the dollars in the tens to maybe $150 billion a year in terms of expenditure to treat adult obesity in the US. It's a huge proportion of our medical spending and much higher than expenditures for normal weight adults. So we have to worry about the cost. That cost is driven, of course, by this tremendous growth in the number of American adults who are obese, and this graphic just shows that growth over time, that over a third of American adults meet that definition for obesity of a BMI above 30. And you can see how it's just zoomed up over the last 50 years in the adult population. Looks like it's starting to level out in the US, and so there's a lot of happiness that it's leveled out, but look where it's leveled out. You know, I don't think that's much to be happy about. We have a tremendous problem that's, of course, driving that chronic disease epidemic. And that is driven by some behaviors that are not so healthy. Let's see if I can get the pointer to show up. And just want to point out, these are statistics on physical activity and healthy eating in the US. And the main point I want to make is that there is no healthy eating in the US. The green bar shows healthy eating, and you can see that the healthy eating chart here has really no green bar. It has a little line up there for prevalence of healthy eating. So American adults don't eat very well at all, and most of them don't meet guidelines for physical activity at a level that would prevent chronic disease or obesity. And of course, that rolls up to risk factors, metabolic risk factors for chronic disease. Of course, sadly, we have the same problem with kids, right? That the childhood obesity epidemic has been a big problem. And this graphic similarly shows what's happened with kids. Really steep rise, both in young kids, school-age kids, and teenagers in obesity, so that about 17–18% of American kids are obese. We're also happy that it's starting to level off, but it's, you know, three times higher than it ought to be. So we have a big problem there. And we worry about that, of course, because children who are obese are often likely to become obese adults and bring all their health risks with them. In particular, they actually start to see health risks that are metabolic manifestations of disease risk very early in life. And this is this sets them up for a lifetime of chronic disease, which is expensive, obviously, and has tremendous costs from a human standpoint. If you look in the middle of the chart, type 2 diabetes in childhood obesity, this is, first of all, never was seen prior to the epidemic, so now we're seeing this, and virtually all of the kids who have type 2 diabetes are obese. So we've got this tremendous epidemic, both in children and adults, with tremendous consequences. So that's the setup, and you know, what do I do about it? Well, I try to move the science into action. So I use this three-part model, these three arrows, and I'll be drawing on this and going back to this, but this really, I think, draws together a lot of the comments that were already made today. If you have good interventions, and you do them, you can expect to see impact. And as scientists and as thoughtful humans, we like to think that if we create good interventions, we will have strong impact. But there's this middle arrow here, and that's really the bridge we need to cross, and this is really tough stuff. So in this presentation, I'll be referring back to this and dwelling a bit on this issue, where for high implementation, we need to have a framework that helps us build organizational capacity. So in out-of-school time, we needed to make sure if we were going to change what was going on, that the organizations could actually do what we were asking them to do. And we needed to make sure that the teachers would do it. So there are a lot of places where all of this can fail, and the truth is it often does fail. And the issue is, how do you get back up and keep going with those failures? In addition, it's also true, of course, that prevention costs money, just as disease costs money. And of course, the theory is that we'll see savings at the end of the road, and that's true. But the investment in doing the prevention and making changes in organizations can be really scary up front. And so we work with organizations in the out-of-school time setting to kind of mitigate that. And one of the things that President Clinton's initiative has done is actually pull together some of the big food producers in the U.S. to come up with discounted foods that out-of-school time programs can now purchase, because they said to us early on, hey, we can't feed kids fruits and vegetables every day. That's really expensive. So the Alliance for a Healthier Generation said, okay, we'll fix that. The work in out-of-school time is embedded in a social ecological model, and this wraps up, again, comments that have been made earlier. When we try to do environmental interventions, the reason we're doing that is we have a theory that if you change the environment, people's behavior will change. So for children in out-of-school time programs, we want them to be in programs that provide healthy food and physical activity opportunities. And the theory here is that if we can create policies that tell them, policies and guidelines that say, hey, this is what healthy eating looks like, this is what good physical activity looks like, this is what you ought to do, then over time, if we change their capacity, they will implement those changes. And here's the thing with kids, and Ken LaBrush set this up for me nicely. You know what? If you offer them healthy food, they'll eat it, particularly if you don't offer them unhealthy food. So if you change the environment, you can change kids' behavior. Our initiative has been a national effort now to align food, beverage, and physical activity offerings in out-of-school time with evidence-based guidelines and best practices. So it sounds very much like the clinical initiatives we just heard about, right? We're going to prepare evidence-based guidelines, and then we want them to happen. And again, just as in the clinical setting, there's no guarantee of them happening. So we put together a coalition to drive this work, and that is really a critical part of the story. So let me jump into that in a bit. So what our first task was in putting the coalition together was to address some of the data that we were seeing about kids in the U.S. So take a look at this. This is a shocking graphic about physical activity in the U.S. among children. Just note the very, very low height of the bars. So this is the prevalence of children getting adequate physical activity in the United States according to current guidelines. The young kids are in blue, and then teenagers are in green and red, and the boys are separate from the girls here. The basic story is that kids don't get enough physical activity, and in fact, you know, for girls, particularly when they get to the teen years, none of them get enough physical activity. So we have this tremendous problem in the U.S. We now have objective data that shows that this is the case. And we asked, well, what can we do in the out-of-school time setting to offset that? It's also true in the U.S. that just like their parents, children don't score well on healthy eating ratings either. So look at the height of the red bar, right? You know, kids in the U.S., these are teens, they just don't eat well, period. There's hardly even enough variability to talk about. What we did for the out-of-school time setting was we brought together a group of people to talk about what we could do that was evidence-based. Well, conveniently, the United States has put out physical activity guidelines recently that are evidence-based. There's wonderful science behind them that show that children and adolescents should do about an hour a day at a minimum, of physical activity. So how do you build that into the day? If you think about my 3-arrow diagram, one of the things I said was you have to have an intervention that's good for the setting that it's going to go into. It's got to be appropriate and acceptable in that setting. Well, we've got after-school programs. They're not going to give up an hour of that for physical activity, but they were willing to give up half an hour of it. And so we created guidelines that said, for an after-school program, there should be at least 30 minutes of intense or moderately intense physical activity that all children can participate in. And that's how we translated this guideline so that it was applicable and realistic for the setting we were working in. At the end of the day, here's what happened. So this group of 4 of us who were sitting around 2008 said, let's get the right people in the room. And we got 12 people together who ran all the big NGOs in the States that deal with out-of-school time. It was the YMCA, it was Alliance for Healthier Generation, Boys and Girls Clubs, a number of big organizations that you may or may not have heard of. And what we did was we put together 11 standards, the healthy eating and physical activity, HEPA standards, and best practices. There were 11 of them. There were 6 in healthy eating, 5 in physical activity. One of the things that our coalition told us, these 12 people told us, was that what we needed to do, was not just tell us what to do, don't just tell us what should be on the menu, don't just tell us what the physical activity should look like, but tell us what the program should look like so that we know we can build program capacity to make the changes and sustain them. So not just what's on the menu, but what kind of staff training do we need? What kind of nutrition education is worth implementing? How do we set a standard for role modeling by teachers? How do we make sure organizations know that they need to commit budget to having healthy food around? And how do we make sure that they have environments that support healthy eating? A common problem we ran into was that we'd go to programs and they'd say, great idea, I'd love to serve more fruit, but I don't have a refrigerator. Or I don't have a place to wash the fruit, or I don't have a place to cut it. So having environmental support for these changes turned out to be a really important capacity building step. So we put it right in the standards and in parallel for physical activity. So again, we moved the science to action by getting a group of people together, a few scientists, but mostly practice people, and said, let's build some standards that are based on science, they're grounded in theory around behavioral change, and they fit in the after-school setting. And now let's focus on implementation by helping people understand what kind of organizational and staff needs need to be met before we can do the work. And if we do that, we can hope to change these environments and have high impact on kids. Our focus really was on the environment, not on the children per se. I want to make that really clear. You've got to get the implementation straight before you can see any kind of impact. Skip that. So, So in the past few years, here's what's happened. This went from 4 people to 12 people. It's now a go-to. It's a thought leadership group with about 30 members that meet. We meet like monthly on the phone and once or twice a year in person. And we're really moving these standards out into the field. We created standards. They were adopted by 3 of the major organizations that provide out-of-school time services right off the bat. So the National After-School Association made them their policy statement, and then the YMCA adopted them and said, we're going to put these to work in 7,200 after-school sites by 2015. And then Alliance for a Healthier Generation stepped up to the plate and said, we're going to teach after-school programs how to do the implementation work. We got the leaders together, and people have started to follow the leaders. So now we have 30 coalition members or more. It seems to grow from time to time. We've actually started to have subcommittees. We're turning into a real organization. We've had funding from some major funders in the U.S. to do the work and to do research on the work. Had a couple of peer-reviewed publications and several evaluations ongoing. As the press release said at the beginning, we're looking at impact about 4,000 sites associated with the Alliance and probably another 13 or 8,000 sites associated with other programs. So in a few years, we're going to have about 13,000 after-school sites around the country that are using them. So as I wrap up, I want to bring a few points home. First of all, this is not free, right? You know, it costs money to train staff. It costs money to buy supplies. It costs money, big money, if you start multiplying that by the number of sites we're talking about. And certainly there are opportunity costs involved as well. If programs are focused on making these changes, they may not be doing other changes. So choices have to be made in terms of doing this translational work from science to action. When I looked at data from the region here, I was thinking to myself, well, I wonder how applicable my work is here, and I did find a study that I'm just giving an example. Perhaps the author of the study is here. One of the things that interested me here is that your prevalence of overweight and obesity is actually really similar to what we have in the States. What's not similar and is different here is the prevalence of underweight here, which is much higher than what we see. And so just from this chart alone, I have to say we have a lot of work to do to figure out what's really happening on the ground here and how to intervene from a public health standpoint so that we improve health for all children and don't put some children perhaps in jeopardy by reducing access to calories in other groups. That said, I do think that this model is generalizable, and what I've been doing with this model is creating a dashboard. So now when I work with the Alliance and with other clients, I kind of keep this out on my desk. This is the three arrows, but it's turned into something I can look at and sort of check off as I'm discussing projects with my colleagues from the Healthy Out of School Time Coalition. We talk about this translation piece in particular. We already got the intervention piece kind of put together. We've got a lot of adoption going on of those standards, but now we're in this translation area, and we can think about these things in a really organized fashion. What do we know about organizational capacity? What do we need to do to improve it? What do we know about staff capacity? Really important here, and someone mentioned this earlier, is performance management. Do we have action plans for making the implementation happen? Are they good plans? And is there any accountability? You know, humans have to do this work, and you know, left to our own devices, we will not do work, right? You know, when we're really given that opportunity. So if things are difficult, it's even less likely that the work gets done. So accountability and performance management become really important in the translation of science into action in public health. I always like to point out, too, that there are two other pieces to translation. It's not enough to say, we're doing the work, we're doing the work, we're doing the work. You've got to celebrate when you get the work done, right? And you have to make sure that people know that you achieved it. That's really motivating to others who come behind you, and it's motivating to the staff themselves. And so having some way to measure and celebrate achievement and communicate success is also part of this translation story. Things don't spread if other people don't know about them. And success, of course, breeds more success. So in conclusion, again, I want to wrap back to the role of the scientist in all of this. So I'm the one of a couple of scientists on the coalition, and we see our role very much as facilitating this translation and making sure there's attention paid to the science behind the standards and kind of keeping people apprised of not going off track and kind of making up stuff about what is healthy eating and what's good physical activity. So we have that role there, and it's really important, but the real work done on the ground isn't done by the scientists. It's done by the partners at the community level and at the NGO level, and it's that partnership that really makes the work happen. Thank you.
Thank you, Jean.
شكرا جين. سوف ننتقل إلى
I'll move on to the second speaker, Dr. Mahmoud Fikri. Dr. Mahmoud, to my left here, was the Undersecretary for Preventive Medicine and Health Policy Affairs in the Ministry of Health at the United Arab Emirates. That was as recent as the last year. He's a member of the International Advisory Committee of the Vaccine Infection Control in the WHO, and a member of the Board of Directors of WHO Center for Health and Development Research in Japan, Kobe, and also running member for the advisory board for the GCC Council. He's a dermatologist by training, and he has held many public health and administration positions, chairing multiple committees for the United Arab Emirates, including disease prevention control, drafting law on tobacco control, national diabetes guideline on obesity, and he's also on the National Diabetes Board. He headed the delegation of the country to the UN Special Summit for the development of UN Political Declaration for Control of Non-Communicable Diseases. He currently on the advisory board for the GCC Health Ministries Council, and he has won several awards, including the UAE Health Foundation Prize, Geneva 2003, and the 2011 International Council for Control of Iodine Deficiency Diseases. So please join me in welcoming Dr. Mahmoud Fikri. Mahmoud.
Thank you very much. شكرا جزيلا. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسوله الأمين. أصحاب السعادة، الإخوة والأخوات، الحضور الكريم، السلام عليكم ورحمة الله.
Peace be upon you all.
And the speakers, good afternoon after lunch. I hope that everybody will be awake so we can go through this presentation. My presentation will be in Arabic as requested by the center, so that translation is there. You can use your headphones for the translation. Also, I will try to translate part of the presentation while I'm presenting the slides. الأخوة والأخوات بنبدأ.
Ladies and gentlemen, we will start our session. We will speak about obesity in the GCC. In the beginning, I would like to thank Dr. Jamal Suwaidi, the manager of the ECSSR, and the scientific members of the RTI for their invitation and to invite me to shed the light on a very important problem, not only in the region, but in the whole world. Obesity is really important. We will speak about the problem, how to differentiate between several types of obesity, and why we gain weight, and how to benefit from the surrounding environment in order to improve the weight and to have a good life. And we have an average age in the UAE of 78 to 80 years. We have to keep our weight, and this is the responsibility of the preventive medicine staff. In the last century, we faced so many problems, so many diseases. These diseases caused so many world problems like cholera, like malaria, and we face so many mortality, and we were looking for vaccinations or drugs to face such diseases, but we could get rid of such diseases and to get rid of a lot of them, and also the polio, and we are on our way to get rid of it. But is it enough? As long as we live in this planet, we always face challenges, and there are new challenges for this era. After facing such diseases, we are facing other diseases. This morning we were speaking about prevailing diseases, and the United Nations spoke about them. What are the factors leading and causing cancer, cardiovascular diseases, diabetes, and respiratory diseases, and others? There are common factors that we call obesity. Obesity is a common factor. These countries currently, after this phase, getting rid of communicable diseases, we are facing obesity, and most of the third world or developing countries are facing the disease. How can we face the new challenges, which is obesity? The WHO, communicable diseases are causing the death of 7 deaths by 2020. And obesity is the most important factor causing non-communicable diseases. And also the United Nations says that 65% of people in the world are dead by obesity more than underweight. So obesity is causing death more than underweight. And this problem, and facing this problem, needs patience, and saying that there is no impossible. We have to have concerted efforts to face obesity. What is obesity? In general, is accumulation of fat in different parts of the body, but the WHO made in order to say that this person is overweight or obese. Overweight and obesity, the factor differentiating is the body or the BMI. We see the height, the weight, and there is an equation, and we have a percentage. If it's less than 25%, this person is normal, and we will see the pictures. But if this number is more than 25 to 30, so he has an overweight that he must get rid of. But over 30%, so we are facing a problem, and the person is facing obesity, and we can treat it differently, as we see. But the first one and the last one, and the obese person could be like the first one. But what are the causes of obesity? Some people are getting more calories, more than their energy, and eating high calorie food, and at the same time we were eating that in our coffee break. We must not eat such food, or we can consume such food in small quantities. Also, the lack of exercise, because exercise is not problem. 150 minutes per week is acquired by each person, or required. So you can walk every day in order to keep your weight. There are some other genetic factors. Some of the communities and people are prone to overweight. There are some biological diseases leading the person to overweight, and some glands also, if there are some abnormalities in the glands, they are causing also obesity. And some people are eating a lot and having a good appetite. And of course, there are some causes, like some economic and social causes. What are the complications? I'm speaking fast because I would like to reach the cost. There are some health complications and psychological and social complications. We spoke about the health complications, high blood pressure, stroke, and diabetes, and so forth. And there are other complications. We see that the obese person always, especially among children, are facing psychological problems like low self-esteem. They always feel lower than others, and they feel that what they are eating is wrong, and also stigma. Also, lots of people are not buying the clothes that they like. They are always looking for the extra large size. So if they get even the extra large size, it will be higher in price. What are the world's estimates? Almost 1.4 billion adults are facing obesity. 500 million are facing obesity. So the body mass index is more than 30%. But the problem in 2020, we will find that for 15% of the world population, which means 1.5 billion people will face obesity, which is going to be a problem. We will face another problem, that obesity is starting among children. We notice that 155 million children between 5 and 17 years old, which is the age of good exercise, are facing obesity. This increase, 42 million children below 5 years old, and 35 million are living in the developing countries, as they are, and the problem of developing countries are facing the previous diseases and the new diseases. From 2005, we see an increase in world obesity. And as Dr. Jean said, that this epidemic is increasing from 2005, 2015, and 2020. There will be an increase of 50%. This map is showing the countries including obesity. The dark green means more obesity. The regional situation. Speaking about the regional situation, we will speak about the East Mediterranean region. We have two regions, all the Arab countries and other non-Arab countries like Pakistan and Iran. And we conducted research on the Arab countries. The number increased in developing countries 4 times. This is really. We would like to thank Dr. Tawfiq, who sent us the article a couple of days ago. The number of people facing overweight and obesity are increasing 4 times since 1980. So each 10 years, the number is increasing by 4. And In 1980, we had 250 million people, but the number now is increasing. Is it increasing because we are not facing the problem or not solving the problem? We don't understand this problem, or people are considering it as a factor or a main problem. As Dr. Yunus mentioned this moment, how they are implanting the stent or the valves, but the main reason is obesity and higher energy consumption. In the US, Latin America, and Middle East, we are facing obesity. Maybe the genetic problems are a factor, but in the United States, 70% are facing obesity. That's why we see that the size is really great there. So we see in the Gulf states and the North Africa, but most of them in the North America. And obesity in the East Mediterranean region, we see in Palestine and Libya, and the WHO.
As Dr. Tawfiq called them, the adolescents aging between 15 to 18, and their weights and heights were measured to know the BMI. What was the result of that study? This study showed some data about overweight and obesity among adolescents, the spread of obesity and overweight among the Arab adolescents in comparison with the advanced nations, especially the UAE and Kuwait, and the change in food or nutritional behaviors and customs led to a change in the values and customs that were proper to lifestyle, when people used to go on bikes to schools and go on foot and so on. But when the situation changed and the patterns of life changed, we should have changed our own lifestyle accordingly, and obesity among adults came to a critical point in these countries, and there is an urgent need to have programs to prevent obesity among school children in these countries. And this is the result of the study. This is a study regarding the Eastern Mediterranean statistics, showing you the state of Kuwait. 27% are overweight and 23% overweight, 27 obesity. The same thing between Libya and UAE, and we have also a study about the city of Sharjah, 16% and 15% in overweight, but this finding changed, in fact, when we compare them to other findings. And obesity in the GCC states, these are a group or a set of studies by a team of researchers collecting all these studies, existing studies, getting some of these results. And Dr. Tawfiq, there is no one single study of, for example, the families in GCC as a systematic study for this subject in all GCC nations in all times, but there are kind of sporadic studies here and there, and therefore we take some samples, and this team of researchers collected these studies in 2010 and came out with almost the same results or same findings. And you'll find that the problem we see here is that obesity among children less than 8 years old, that is only constituting 10% in comparison with those children of 5 years old. In fact, this is a big problem. It means that within 5 years they will be very obese, even after the age of 18, and the body mass index will be more than 40. And as for the age 5 to 14, you will find most of these findings. Other studies combined some sets of statistics from the previous studies of the Gulf nations, and there are 45 studies in the region. And there is one of my colleagues, Dr. Leila, from the UAE, was a member of that team who combined and summed up the results, and they found that the overweight was 25 to 50% in the GCC states. We are not talking about obesity, we are talking about 25 to 50% overweight. That is not obesity, and the spread of obesity between 13 to 50% in these countries. But this is not the problem. The problem is that it increases by every 5 years, and the spread of overweight and obesity among women is higher than that of men, and this is a phenomenon that increases with the passage of time. This is a conclusion from all these studies. Now we talk about obesity in the United Arab Emirates, and this is a problem, in fact, a common problem in the United Arab Emirates, in particular as part of the Gulf nations, as a number of youngsters and adults suffer from this problem due to the lack of physical activity. For 39% of children in UAE suffer from overweight, and 15% suffer from obesity in 2010, and I'll explain it. I did it in collaboration with the Ministry of Health on 2 stages in 2005 and 2010, and we have found that the gap is increasing, and the results of this survey show that 39% of the children in the UAE, according to the first study 2005, 39% of the children in UAE suffer from overweight, 15% of obesity, 26% of the students who exercise physical activity by no less than 60 minutes per day at school, only 26%, while others do not have any physical activity. 51.3% is the percentage of the students who spend 3 hours or more in their own daily activities, while others spend it in front of computers and TV screens or displays. You see this timetable showing the difference between 2005 and 2008. The obese children at the age of school or school age, that was a study conducted by the Ministry of Health and Atlanta and the WHO in different places in the Eastern Mediterranean. In the UAE, we did it twice, in 2010 and 2010, and you will find that the obese children of overweight were 21% of the students. 38% turned out to be in 2010, so it was a double fold, and those who suffered from obesity were 12% in 2005, and the same group we found that they have risen to 15%, and this means that the percentage is rising among children, and the other problem is that it is increasing and intensifying, and these red lines show you that the students who have physical activity are decreasing, and therefore because of overweight they cannot practice their physical activities. Let's talk about the economic burdens of obesity. One of the studies in the Eastern Mediterranean, we don't have accurate indicators and studies to measure this cost or this economic cost of obesity. You should have sufficient information, not for the medical treatment, but for the other economic factors, and this study conducted in the United States in 2007 on adults between 20 to 64 years of old, showing the cost of 18 to 91% more than the normal individuals. See the chart here that if their BMI is less than 20, they spend $3,920 a year. For those for BMI index, they spend $7,500 a year for the normal, as we said, and for the first and the other expenses. For this slide shows you as weight increases, the body mass index, so too the associated medical cost increases, and therefore whenever we take the cost of the obese persons whose BMI is more than 35 or 40, the cost will come to $5,500 every year for medical treatment, and you'll see the expense or the cost here is so high from a holistic perspective. effective. This is the complete, including medications, medical examinations, surgeries, in $160 billion, 38%. What about the other expenses? Overnutrition, overweight, XX large garments, and other slimming programs. $140 billion, Mike. $140 billion on clothes. Imagine, and absence from schools and work, and lack of productivity. 29% are absent from schools and work, and this is a big problem because of overweight. They do not have physical activity, and thus they cannot attend schools, school classes, and they cannot go to work. Pardon? There are no motivations. No, health is the crown of all these motives, and once you are healthy, there will be nothing that would compensate you. Take this example. If we take, how did they calculate these expenses? For the cost of individuals, overfeeding, 90 billion, taking, for example, one steak, X large clothes, slimming programs, medical treatment for the obese persons. If you see the medical insurance and private insurance, they'll cost 60, 80, 40, but the absence of work will cost $30 billion for the absence from work, lower productivity. Also, they stay at home snoring, and average life expectancy will come down. Also, all these are expenses reaching to $450 billion, while the government spends on medical treatment $100 billion, and it's a huge problem. And I don't think that these figures will be forgettable, but if we think of them, we will find that each one of us will go back home, and they will take a weight of their body, and then they'll see what will happen if your wife discovers these things. And then we'll see the scale of expenditures made by or conducted by McKinsey Group in the Gulf region in 2006, spent almost $12 billion on these problems. In 2025, we expect to spend $57 billion, from 12 almost to 60. Fivefolds, as we have seen that we will witness lower productivity, overweight, should have clinics for also obesity surgeries, and so on. And now the most successful business for surgeons is that of slimming and reducing weight. So once they get rid of that overweight, they eat again. Yes, man should eat, of course, but they should know what to eat and how much to eat, and so on and so forth. And if we come to the diseases of, Dr. Yunus talked about this in cardiovascular diseases, and in 2006, these cardiovascular constituted 12% of the total cost, and 25 cost 42 or 44% in the future. All of these expenses go to cardiovascular disease due to obesity, and the same thing applies to this background. Now we come to the solutions and interventions. There is a program, an increasing problem among children and adolescents in comparison with adults, and this region suffers from this problem. Shall we stop? What are the solutions? And some researchers provided or presented some solutions in a package containing, for example, if we come to the health sector, we should have health clinics, periodical centers for weight, length, and His Highness Sheikh Mohammed bin Rashid Al Maktoum, UAE Vice President, Prime Minister, and ruler of Dubai, sponsored the process of brainstorming in Dubai, and one of the components or strategic components of this sector is to have compulsory examination of weight and blood pressure, and there must be a kind of compulsory recruitment for the young people from the age of 18 to the age of 30, and this has been a long-awaited decision. Once they are recruited in the army and they exercise physically and mentally, that would sharpen their characters and make them slimmer, and there are also pre-marital examination centers, and this is also obligatory in the United Arab Emirates, and people usually do not go to the examination centers before even engagement. They try to reduce their weight. I mean, men and men, if he sees it, she sees her overweight, he would not accept her, and so on and so forth, vice versa. There should have been specialized centers for the treatment of obesity, that is the surgical intervention, and also conducting of health surveys to know and trace the spread of obesity, setting forth plans to reduce these things. As for the solutions at schools, see it through pictures here: exercises, swimming, nutritional food, and periodic examination. And we in the UAE have such an examination at the school age and after every 4 years, and we did 2 studies for the students. Very simple. Before or preschool age, we take the data, the height and weight, and some simple tests, and every 4 years we follow up the provision of healthy food in canteens, raising awareness about nutrition and sound nutrition, and also the exercising and also the physical activity. While we were children, we used to play football. Now and nowadays plays football, they can watch it on BlackBerry. They go out to see what happens on the BlackBerry on their iPhones and follow theirs. As for the media and journalism sector, and this is a picture of for a booklet issued by the Minister of Health 4 years ago in collaboration with the UNICEF, entitled Mufid, which is useful, a very useful story showing this child, how obese child was targeted by those children around him, and also the discipline of commercials about food and beverages. And we ask the Minister of Health to put all these foods and beverages should be licensed and permitted to be declared, showing their own nutritional ingredients, and also raising levels of awareness about children and education through fun. And it's very easy to access information. All children at school age have their own iPhones and laptops and WhatsApp or whatever you call it, I don't know, and they can speak through, so we can send them SMS messages and pictures especially, and even the cartoons. They are very useful and helpful, discussing the subject of obesity and how to prevent it in an attractive way. As for the labor sector, the setting up of mobile or fixed clinics in the work sites where we have a large number of employees, they can go to that clinic to be checked by a doctor and nurses to check their own weights, blood, and other things, and to have their own files and to follow them. And also in South Korea, for example, there is a company that produces chairs and tables for offices with a treadmill as part of the chair, and you can move your body and you can move your legs. And these products were exhibited in Switzerland last summer, and it is expected that these things will be exhibited in the Arab Health exhibition to be held in Dubai. And while you are sitting, doctor, you can exercise, you can also circulate your blood and raise levels of the staff awareness and motivation. What is the motivation here? It's not a matter of money, it's a matter of health in general. My time is over. I still have half a minute only. This is a global problem, an increasing problem, deteriorating, and we have explained it, and we have explained it now. It is caused by many reasons. We cannot say it's overeating. There are hereditary factors, the environment, method of eating, and other things, and this obesity leads to serious complications, and it also increases the economic burden on states and communities and could be prevented, but the cost of treatment is very high. Yes, it could be prevented. And finally, sound nutrition and physical activity, 150 minutes per week, are the basis of healthy life. Thank you very much. And those obese children say hello.
Thank you, Dr. Mahmoud, for this enlightening presentation. So the next phase of this panel will be the panel discussion. We have three panelists, one of whom, Dr. Hala, has sent her apology that she will not be here. The first member of the panel is Dr. Mariam Al-Jalahma, to my right. And Dr. Mariam is currently holding the position of Assistant Undersecretary for Primary Care and Public Health in the Ministry of Health at the Kingdom of Bahrain. She's the Assistant Professor at the College of Medicine in Arabian Gulf University in Bahrain. Dr. Mariam has been a member of the Executive Board of the Health Ministers Council of the GCC countries, and she holds also a fellowship of the Arab Board Council for Family and Community Medicine. She has several degrees and diplomas, one of which is the High Study Diploma in the Medical University of Dundee in Scotland, and the Honour Diploma in Healthcare Management from the Royal College of Surgeons in Ireland. She specialized in medicine education and health management. She's a member of the Higher Education Council and the Board of Trustees of the Arabian Gulf University and the Board of Princess Al Jawahra Center. She's also the Vice Chairman of the National Committee on Non-Communicable Disease Prevention and the National Committee on Tobacco Control in Bahrain. She has earned many acknowledgement and an award, one of which is the First Class Efficiency Medal by His Majesty the King of Bahrain in 2011. She was also honored by Her Highness Sheikha Sabika bint Ibrahim Al Khalifa, and she was given the Award of Excellence from His Highness the Minister, honoring her for a pioneering of Muharrak, the Muharrak, pioneers of the Muharrak, who have made outstanding work in the community. And she was also awarded the Gold Award for Best TV Health Program for Gulf Radio and Television Festival, and that is focused on health as well. That's certainly dove well with what we just heard about the need for more awareness from the media. And she got the Eastern Mediterranean Region Award for Tobacco Control. So, Mariam, welcome to the panel. The second member of the panel is Professor Samir Al-Adawi. Professor Samir is the head of the department to the extreme right here, head of the Department of Behavioral Medicine at Sultan Qaboos University in the Sultanate of Oman. And he's previously was the Fulbright Scholar at the Department of Physical Medicine and Rehabilitation at Harvard Medical School at Boston. And he was also, his research was sponsored by the Matsumi International Foundation at the Department of Psychomatic Medicine, the Graduate School of Medicine, the University of Tokyo, Japan. His area is actually an interesting area, and in the psychiatry. He currently works in the Institute of Psychiatry, and he earned his doctorate from the Institute of Psychiatry at the King's College in the UK. And his research focused on non-communicable disease with the interesting twist of psychosocial determinant of behavior or lifestyle. And I think that's an interesting dimension that we would like to hear from. So we have our panelists with us. In light with what we just heard from the the two presenters that we just listened to. We have made the case, and everybody knows that the case is made for, in terms of the alarming rate of obesity, the implication in terms of health, the cost, and the difficulty to getting behavioral changes. And then a summation of this one, we could see that there is a need for an integrated approach that tackle it from different angles, because it's so complex and you can't make a dent on it from one area only. Integration, but also incremental steps, because you cannot revolutionize your way out of obesity. So increment is setting realistic goals that you can reach through part of that implement. And also make it at a larger scale to make an impact, because small studies will not make the difference that we would like to see. And also focus on the environment. Yes, we can educate people, but the key is to move to implementation and adoption in the long term. So that was Dr. Rice's presentation that focused on the environment. Use of technology also. Our children are tech savvy, so since they love technology, we could use it as a way to getting into them. But also use the media, and that's the specialty of Dr. Mariam right here, in terms of also getting a change of behavior, sustained one over time. So in light of all of this, one would say, okay, we know all of this, so where do we start? Is there a magic sequence of action that will allow us to succeed? Are there examples that can be adaptable to the GCC context, for example? And then what is the role of, let's say, legislator and government in telling people what to eat, when to eat? I mean, there is a dilemma in there. I mean, we are trying to change behavior, so there is a lot of moving parts. So I'd like to start from my right, Dr. Mariam. What is your view of this, and how can we change minds and then lead to change in behavior?
Thank you very much, and I would like to thank the presenters, Dr. Jane and Dr. Mahmoud, for the very interesting presentation. I want to lose 4 kilos only, and it's very difficult. Believe me, it's very difficult. It's not easy. And to know how difficult, the WHO put the indicator of decrease of obesity as a risk. They started by saying reducing the prevalence of diabetes 30%. And after a lot of discussions, they said, halt the increase in obesity and overweight. Just halt for the next coming 15 years. So this is the final indicator. مجرد وقف الارتفاع في السمنة. They did not say decrease anymore. So it's very difficult. If we tackle obesity, we will be tackling 2 risk factors for NCD, which is unhealthy diet and physical activity, which will help us reduce the prevalence and tackle NCD as a whole. In the GCC countries, look at what our government subsidizes for the citizens: flour, sugar, and meat. The price of fish has risen very much. The price of vegetables are rising to the degree that 1 month ago, the tomato was so high that the citizens started to boycott buying tomato. And they made it 50% less. So I think our government really have to think of whether, and I was thinking of this, my government want to stop the subsidies and give money to the citizens instead. And I was wondering if this is a better choice, so we can help people have better choices. And instead, we support fishermen and farmers and whoever are bringing vegetables to us to reduce the price. Let me share with you what we are doing in Bahrain, because you asked me what are intervention. I think the best thing is to, as Dr. Jean said, and she gave us a good example of implementing a community-based intervention that is very simple to implement. In Bahrain, we had we are tackling overweight and obesity and other risk factors in many ways. We started to implement early detection programs in the community, and I have Dr. Abdel Hussein here with me from Bahrain. He's leading the Protect Your Heart campaign. They go to workplaces, they screen the employees there. They started by the government. They screen them for weight, height, and cholesterol and sugar. and they give them advice and book and refer them to their health centers for those with specific, like more than 2 risk factors, to introduce them into programs. We introduced early detection clinics in 6 health centers so far, very successful, and I would like to share this with you because we asked the doctors in primary health care that choose any, we don't want to overload you. We are not going to take more for your consultation time. Choose 10 patients that you see daily, refer them to a nurse in the clinic. She will do the risk assessment and she will give them advice. We chose those with more than 2 risk factors, and we, with the help of Ministry of Education, giving us the schools to do exercises, Supreme Council of Youth, who gave us the trainers, and Ministry of Social Affairs, who gave us their centers, we introduced healthy cooking programs, exercise, and counseling on how to tackle stress and relaxation. The results after 6 months were amazing. There were reduction in weight, there were reduction in cholesterol, and I mean even the low density cholesterol. When I presented this, Dr. Tawfiq was there in one of the sessions. They didn't believe me. They said this will need 5 years to be tackled. No, it doesn't. If you give them, and you give them a logbook and follow them up, they are very enthusiastic, and we have recorded interviews with the patients who went into the programs. We have nutrition clinics in the health centers that will tackle those more than 35 body mass index. And in the schools, we develop programs such as the Green Apple program to encourage them on a healthy diet. We are monitoring canteens. We don't allow them to sell anything in the school that we don't consider it healthy. At least there is no Pepsis and colas. They are not allowed to sell that in the schools. And we have a sample of program where we included the families in it. And this is maybe, Jane, I'd like you to comment, because I didn't see in the presentation what were the role of the families. Because behind every obese child, there is a family that has is forcing him to go through an unhealthy diet. If you see a child healthy, there is an unhealthy family behind him. And maybe the program is to tackle the whole family as such, and not just the child. And what else I want to say is, I wrote some notes while Dr. Mahmoud was talking about premarital screening. Maybe we should delay marriage until they lose weight. Overall, I think that the problem now that we are seeing now, I don't want to be long on this, is the surgical interventions. They are becoming fashion in young adults. You don't believe it in GCC here, how many young adults are going to bypass surgeries, and I don't know, dissection of the stomach and all the others. It's the easy way, guaranteed to lose weight, and it's a fashion today. I think overall, Doctor, I would like to say that it is very important here to recommend the following: to promote the role of primary health care in the prevention of NCD risk factors, which includes obesity, plan and implement community interventions that are easy and doesn't cost a lot, and promote the role of schools. And especially that, like in Bahrain, we made a deal with Ministry of Education, never cancel the exercise class, the physical activity class, to give them math or give them Arabic. We have TOCA guarantee with that, especially when they are near the end of the year school, they start, stopping the physical activity. And ban advertisement, as you said, Doctor, ban advertisement on fast food and non-alcoholic beverages like the energy drinks. Thank you very much.
Thank you, Dr. Mariam. And now to our second panelist, Dr. Samir. Given your area of in psychology or psychiatry, is there? How can one? We know that the issue is so complex, but the psychological part is not only a part of the problem about self-esteem and other things, but it also could be an angle for entry into the inner workings of the individual and how they can change their behavior. Could you comment on how your experience kind of with the lifestyle changes and then and the media and so on, how could that help us into a more effective way of controlling the issue?
Thank you, and I think our previous speakers have already touched base most of the theme here. But I think one thing we need to be very cautious is that we don't need to ostracize, obesity, because every talks I go, it's actually become an object of fun, and everyone's contemplating new mechanism to what to do with these people. And we are going to run into the same theme what we did with drug addictions or other cultural devalue conditions. So I think this has to be very much on the, in our head as we're thinking how to come to grip with this problem. As my colleagues have said, the mantra I think should be biopsychosocial approach. It should not be psychiatric problem or should not become a medical problem. We do need to look at this psychological factor, medical factor, as well as social factor. As we know, this is a multifactorial, its origin to multifactorial factor. Within this context, I think the discussion also should come at the role of culture. Western models have succeeded, for example, just like tobacco now, as our colleague here has said, they are coming, there's some glimpse of hope. Maybe obesity is, is stabilizing or it has reached a plateau. We are having a different culture here. Traditionally, our culture actually value, people who are bigger. I look younger, but I'm old. In my generations, if my wife was thin for very long, my mother would have been very upset because we always thought bigger size is associated with fertility. So biopsychosocial approach, I think it's a way forward. But also let's not overlook the fact that, our own existence, we rely on economic growth. And economics, in fact, correctly been kept as the theme of this afternoon session. We know, for example, economic growth trigger us, which we all like that, but also create a sedentary life, which my colleagues earlier and today have already alluded. How can this impact on, triggering cardiovascular problem and, sedentary life leads to obesity. We also aspiring to have economic growth. We also, as a result of that, we need to be very cautious that we tend to shackle our children inside the house, so they could become like us in the future, and they miss what we missed in the childhood, like going out and play in the garden, riding a bike and all that. Also, paradoxical is that the very economic growth that we are striving for, they are also creating problem of, removing those empty space. You and I, when we were young, we used to run around with a bike, play football, or simply walk. So, as I was asked to reflect on the behavior side, and I think this issue should not actually be overlooked. Economics, we love it, but it has a detrimental effect. So in the end, go back to that theme I pointed earlier, we need to tackle it from biopsychosocial approach, which is not new. Most of the discussion has alluded to that. Thank you.
Thank you. Thank you very much, Dr. Samir. We did start late, but we kind of made up for the late start. We have a few minutes for questions from the audience. Are there any questions? Go ahead.
Hi, right here. Before I ask my question, I want to describe a study from which got me to think about this question. The study looked at health risk or death risk with people over 14 years adapting to some certain healthy behavior, 4 of them. So if you took on 1, you reduced your risk of death. If you took on 2, you reduced it even more. If you took on 3 more, 4 even more. But the interesting part about the study is that they looked at that on people who are normal weight, heavy, or obese. And you see the same effect. You reduce your risk more adapting healthy behavior. So now my question is, when we try to combat obesity, should we be really combating obesity, or should we be combating unhealthy behavior or unhealthy living? And you may think that it's one of the same thing, or one may lead to the other, but in reality, there's more challenges, I think, to combating obesity that you don't see with combating healthy behavior, because obesity has like this genetic component that, no matter what you try, you may not be able to combat. There is this achievement and rewards. Sometimes with obesity or weight, it's a goal you may never achieve, and then you get into the self-fulfilling prophecy of failure. Whereas, I don't know, healthy behavior, if your outcome or your goal is that, this is something that's achievable, and you can probably more stick to that type of behavior. So and then there is that image about self-image, which is a very complex issue, especially with children and females, that is a much bigger challenge if your goal is to overcome weight gain versus healthy living. So if you could address any of these points.
Anyone please keep the question and the answer short as well, so we can cover. Thank you.
Thank you. That's better. So that's a great question, and I'm glad you brought it up, because I wanted to address that actually in my talk, and I had to keep my time down, so you gave me my extra minute back. So you're absolutely right, and here's the issue. So when I talk about obesity prevention and obesity epidemic, I actually try not to talk about it just like that. I talk about obesity and chronic disease epidemic. What we're trying to do with our public health work is prevent chronic disease, really. Obesity increases risk of chronic disease, but it's not a guarantee. Not all obese people are ill. The more obese a person is, the more likely they are to have comorbidities. Physical activity and healthy diet have immediate, acute effects on people's health. And this is why we want to focus on the behaviors. You're healthier if you're obese but fit. In other words, if you exercise regularly, than if you're lean but unfit. Your risk of disease is higher if you're lean and unfit. So that fitness element is really important. Now, what happens when you get fit is you tend to become leaner. So that sort of follows the behavior. So focusing on the behavior provides immediate benefits. It improves glucose uptake, it improves lipid profiles. It has immediate impacts. The thing is, they go away. So you have to have a habit of physical activity to get those sort of continuous acute effects. But then there are chronic effects too. So, carrying excess body fat causes biological changes. The adipose tissue itself has some pathological properties. So it's not one or the other. That said, I think we're much better off as a public health community focusing on improving people's physical activity and healthy eating than saying that they need to lose weight. That's really not the focus. And for children in particular, we want to focus on changing behavior. That's why our whole out of school time initiative is focused on behavior while maintaining their self-esteem. So certainly don't want to be badgering them about getting skinny.
We'll get a couple of questions together so that we can 1, 2, and 3. Let's take 3 if we can handle them in a short time. Go ahead.
Thank you very much, and I'd like to thank the presenters for their nice presentations. Dr. Al-Harbi, I'm a pediatric endocrinologist and diabetologist, and also I have interest in obesity. Actually, just to know if it's a problem or not, I am running the only adolescent clinic in Ministry of Health, and I'm running it once per week, and I have 200 patients with diabetes. Just imagine about 20 to 25 of them, they have obesity and type 2 diabetes. it's alarming, actually. It's an alarming problem that we have about 10 to 15% of our diabetic patients with type 2 diabetes where they did not exceed 17 years of their age. So it's a real problem. I agree with Dr. Mahmoud that still we need a good conducted study in all the GCC countries indicating how much the percentage of diabetes among the age school, I mean from 6 to 18 years of age. We need some sort of study. I just want to also share with you the experience I had in France. I spent there 4 years. And in 2003, they found that the child obesity is increasing in France. So what they have done, they have done a lot of programs, including the schools, including the media, to stop, as Dr. Mariam said, that to stop the obesity, not to increase obesity all over the countries. And one of the things that they have done, which is really amazing me, that in all the cartoon for children, the cartoon will take 2 to 3 minutes. And after that, only 20 seconds, from 15 to 20 seconds, there is a message about good feeding, good food, about exercise, about just 20 seconds. And it's continuous. Every 2 minutes or 3 minutes, the child will listen or to hear this one. So to stop obesity in children, it needs all the waves of the community to share with it. Even I said sometimes even the Imam of Jum'ah, he has to share in that and to give some talks about it.
Thank you so much. Thank you all of you, and really I enjoy this session because it is the practicality and at the same time it touch a lot of issues which we has speaking about for the last 15 years in the GCC Health Minister Council. Actually, last year there was an intention to have a GCC conference for economy for obesity. We did for diabetes, we did for cardiovascular and heart in Kingdom Bahrain, and we did NCD in Oman. And the intention to do for obesity, but we face that we don't have a lot of studies to show what is the problem, and we have a few studies. Again, it is as Dr. Mahmoud about prevalence and so on and so forth. So I might comment that I would like the Emirates Center for Strategic Studies and Research to take the lead in this area, to call for all research centers in the GCC. We have CACS in Saudi Arabia, we have in Qatar, Kuwait, and also Oman. They have a center for research, so they can call them and ask them to, and then support the one in Bahrain, support the one in Yemen, and to start like Gulf survey for children, child and family, and so on and so forth. And the stepwise surveillance. This is one recommendation. Second recommendation that I would like to ask all the eminent speaker and discussants to help us and to help the center to formulate some one or two conclusion or recommendation. I wrote almost now 5 recommendations since morning, and I am pleased that Dr. Maria mentioned 2. So this will help us tomorrow to have a clear recommendation, an action-oriented recommendation, an action-oriented recommendation rather than a general recommendation. Thank you so much.
Thanks to you right there. And then we'll get one from here, and then that's about the time we have. Go ahead.
Yeah, thank you very much for the nice presentations. Actually, I want to add to the research that my recommendation is for the body weight dissatisfaction, because most of the studies now, they are working on obesity and overweight, but they forgot also about the body weight dissatisfaction among adolescents. Because in my study, I'm Dr. Halima Al-Sabbah working at Zayed University, and I did a study about associations of body weight dissatisfaction and overweight and obesity among adolescents. And I found a relationship between body weight dissatisfaction and many risk factors, like, for example, communication with parents, TV watch, and many factors that are associated. And it was more prevalent even than obesity and overweight. And anorexia nervosa now also in rising in most of Arab countries. So why not also to study body weight dissatisfaction and body image among these adolescents? Thank you very much.
Thank you. Right here.
Actually, it's not a question. It's a kind of, as Professor Khoja said, I would say it's like practical recommendation, maybe. Now, we are saying like obesity, overweight. I think overweight is good. I mean, compared to obesity. We don't have a scaling system. We jump from very heavy outcome to really very good flowery outcome. We cannot achieve that. It's really difficult. So if we condemn the overweight, it'll be a trouble. Ideal weight, it's difficult to get. Now, I mean, according to what we saw. Now, if you see, we noticed here, all the data we presented about overweight, obesity, cardiac disease, stroke, from 1970s till now. Again, I'm repeating. We see all the reports, they're increasing with all these guidelines and data. We see tobacco, 6 million died last year. Lack of activity, 3.2 million. Raised blood pressure, 7.5 million. They are increasing with all these guidelines from 70s. We hope that, as if we are, the more guidelines we put, the more people die and they go bad. I don't know, we are rough with these guidelines. This is one question. Number two, again, it's important to have a scaling system or scoring system. It's really important. And we have to be satisfied with 10% maybe each year or 2 years, not to 50% or 100%. It's very difficult to achieve. So I think we are a bit rough on our own guidelines.
Okay, thank
which
you.
is important. That point is, Dr. Fikri said, is Korean chairs. I think they encourage laziness. Same with nowadays the militaries. Everything is what they call it, simulation. Even the military is gaining weight. Our military, like really heavy guys nowadays. So it's all a simulation. Well, that's it. It's going up. So we have to be a bit satisfied with a bit of change. Will help, I think.
Thank you. We have Dr. Mariam would have a short comment on this. And you have also a short comment, and then we will wrap up. Okay, I know it's very engaging, but please feel free to talk off the stage with the panelists. Thank you.
Thank you very much. Just to the comment that why it's increasing, although we are putting a lot of efforts, I think we were not putting the right efforts. If you look at the decision of our politicians and parliament, they say more hospitals, more health centers, more kidney dialysis centers. They never put the money in the right place. So that's the answer. And unless we divert our budget and priorities to this. The other question I want to throw is that, is BMI the real measure of overweight and obesity? Because I think a lot of questions have been raised that somebody with high muscle bulk might be the cause of increased body mass index, so it not be the ideal measurements. In Bahrain now we are conducting a research with the International Nuclear Agency to have a study on measuring children's weight using the what we call the safety measures of using nuclear energy. استخدامات سليمة للطاقة الذرية. We will use it to measure the real weight and to see whether it coincides with the body mass index, so we don't know. So maybe to your question, maybe it's not ideal. And the other thing, as we said, we shouldn't push hard. Yes, just let's say stop the increase in obesity instead of trying to gain a reduction in it.
Thank you very much, Dr. Mariam. Dr. Mahmoud?
Thank you very much. I think, there is two issues which is very important. Now, we have conducted two, surveys, global school health survey. It's a very good indicator, and it is easy, simple to do it. If it is implemented within the GCSE, they can easily implement it. And after 5 years, they can again check. But this is not the issue, not the end of the story, as he said, colleague from Oman. So he is saying, can we come to conclusion to say, stop overweight? Just stop, not to increase. If we reach this, that means we are going to do something. If we couldn't stop it, then I think we have to go for dinner. Thank you.
Thank you very much. This concludes our session. I would like to thank the panelists on your behalf, and then please give them a last round of applause for the good job they have done. Yeah, I will encourage all of you to send your comment and suggestion, question to the conveners at your leisure, and then keep the conversation going off stage. Thank you.